and revision consultant arthroplasty in Swansea in the UK. So just a small thing about the unit I work in. So it's quite a big unit. We work in mainly 3 sites. The one at the bottom here, actually, it is our elective site where we do what we call low complexity, high volume, and we do around 900 joints per year. And we receive around maybe 700 to 800 neck of femurs per year. So it's quite a big unit. So I'm going to talk about total hip replacement, and I cannot hide, to be honest, my passion about the surgery, which was labeled actually the operation of the century by the Lancet in 2007. And actually it was deemed the second most even successful surgery in the history of medicine, only next to cataract. So what is a hip replacement? So basically, and in a simple way, it's a surgical replacement of a damaged joint to relieve pain and improve function. So what can cause the damage of the joint? Well, we all know the common thing about what we meet every day about having arthritis. And definitely with time now, even in the UK here and in Wales, with the longer waiting list, so we tend to have more tracheal arthritis presenting to us. So arthritis seems to be the most common cause. Then we have trauma, which is quite another common cause. And I think we discussed earlier the management of these type of intracapsular fracture neck of femurs, whether we're going to talk about the replacement here, a hemiarthroplasty or a total hip. We have here the nice guidelines, which recommend according to, the general comorbidities and mobility status, which surgery the patient will have. Then we have AVNs. Another thing that we tend to see more often at the moment, actually, I think because of the delayed presentation of patients that we are seeing, so more AVNs are presenting, and definitely they present a challenge in themselves, managing them. Dysplasia or other, this is a case of Perthes actually. So dysplasia or developmental diseases, again, forms a challenge about the shape of the bone, the shape of the pelvis, and trying to restore anatomy back again. Previous surgery, another thing that with the rise of fracture neck of femurs, we tend to fix them, and unfortunately, not all the time they go as we plan or as we wish. Again, another common procedure with cannulated screws, and as we can see, it progressed to advanced arthritis. Well, surgery can be up to affecting the pelvis itself or down to the femur. And this was one of my cases actually presented after surgery like this, and she was looking to have a hip replacement. So once we see the patient, I think basic stuff that we all know and we all go through actually, it's the basic thing. We go through the history of the patient, proper examination, and investigation-wise, I recommend normally for most of the patients, just a simple X-ray will be enough. Again, I would like to see it within 6 months, which seems to be, unrealistic. It seems to be unusual to say actually, but here you might find a patient coming to you with more than a year X-ray. Meet patient expectations. So we need to talk with the patient. What is the patient expecting? Is the patient expecting to be running again, jumping? What is the patient exactly expecting? And then PROMS is something, like I said, PROMS is the patient reported outcomes. And I tend to put it as a standard. Every patient coming, pre and pop, it's pre and post operatively. It's not the most accurate thing, but it just shows a trend on how things are going. And at the end, my general advice for myself and everyone is we treat the patients, not the X-rays. So in many occasions, I had patients coming with terrible X-rays, mostly as bad as this. They end up being discharged, and other patients with less bad X-rays ending to have surgery. At the end, it's not one size fits all. So we have to assess, it's a bespoke surgery that we have to tailor it for my patient needs and expectations. So a little bit history about the exciting total hip replacement. So things started back in the 1900s actually by the German surgeon Gluck, who started uses ivory. And then in the States in the 1900s, Smith-Peterson used these molded glasses to cover the hips. So far, these were more resurfacing or interposition type of arthroplasty. Then it was until 1942 when Austin Moore, well, actually, this was a prototype prosthesis. It was made for a patient who initially had a fractured neck of femur, which was treated non-operatively, and actually it has healed. But then he developed a giant cell tumor, and then they made this prosthesis to go and fit it in. Surgery went okay. Unfortunately, the patient died 2 years later. Then Austin Moore started to do the implant that we know about, where he put fenestrations in the implant itself just to help bone growth and to help fixation. And just soon after that, Thompson in the States as well made this cemented implant from Vitalium, and it was fixed using dental cement. And this was one of the first trials to have a total hip replacement. And I think my colleague just before me from Denmark just put the same, well, similar X-ray, which is an Austin Moore and like an ice cone type arthroplasty, which was metal on metal. So this was the case things were until Sir Charlie, well, who was pretty much the godfather of a total hip replacement, had his input in the surgery. So it was mainly started with the PMMA, so the polymethyl methacrylate, which is the cement, and he started to develop the low friction torque arthroplasty with using cement and high density polyethylene. So we just have to say that, well, after this, so this was mainly the main breakthrough in hip replacement actually, and after this it was mainly trial and errors with materials and with designs until we try to get what we are doing now. So Sir Charlie, for example, started with Teflon at the beginning, and this had disastrous outcomes. Then he had to change to the polyethylene. He had titanium stems to start with, then changed to stainless steel. So changes were happening. And then once the cement started, then we found there's a problem with the cement. So we started to explore the uncemented implants. So all in all, things has been going from then, trying to play with the design and the material, trying to get the best implants. So we see the patient, and the patient will need surgery. Well, and I totally agree that we have to first consume or exhaust all non-operative treatments before going to surgery. And I would assume this has happened already, and our patient now is ready for surgery. And I will advise my own patients that I would keep my own joint as much as I can easily make you worse. So I would say it has to be really indicated. Everything otherwise is exhausted. So coming to surgery, hip replacement. So we have the big thing is resurfacing or a total hip replacement. We're not going to talk about resurfacing today. It's a different subject. Total hip replacement, most common, either it's a cemented, where the cup and the stem were both cemented, or uncemented, where the cup and the stem are uncemented. And in this X-ray, we see this is the normal or the standard size uncemented implant, and that's what's called a short stem. We have hybrid fixation, so we can have what's more common, a cemented hip with an uncemented cup, and a very less likely combination, which is a reverse hybrid, where we use a cemented cup with an uncemented stem. So to have a good outcome, so the implant stability and fixation are crucial for the durability of the implant. So it's very important to have a stable and a fixed implant to live. So to achieve this, we need to be sure we put it in the right position. It's well fixed with the right design, using the right material, and paying attention for our bearing surface because of the debris coming out of it. So position-wise, again, I'll try not to complicate things. So mainly where to put the cup, we have the coronal tilt and the virgin. Simply coronal tilt 30 to 50, that's the most surgeon's range. Anti-virgin 5 to 20, and the femoral virgin is around 15. And definitely intraoperatively, well, I will advise that we all should have different parameters how to achieve this position. Fixation, which is quite a big topic in a total hip replacement. So mainly we have cemented, and later we're going to talk about uncemented. Within the cemented itself, we have two types of philosophies. We have either the taper fit or the composite beam. So taper fit is what we earlier, it was referred to by one of the professors between the force closed and the shape closed. So taper fit is one which is very smooth, like this one, we see the extra one, it's polished taper. It depends on having a mold around the implant. And then with creep, one of the viscoelastic properties that with time, that deformation happen and that it is meant actually to subside within the centralizer. When this happen, it will convert the shear stresses, as we can see here, into radial hoop stresses. So there's a shear force happening with the stem. Once this happen and it subsides by creep here, we have this shear stresses transfer to radial hoop stresses and the implant stays stable. Composite beam or shape close is a different philosophy. So it is rough, it is not as smooth, and it's the shape of the implant. And there's a cement, so shape cement and cement bone. And I'll try to clarify this a little bit more here. So I've got the cortex and a cancellous bone. So here, this is the normal cement and or taper fit, and this is the composite beam. Doing the taper fit, we use the normal boxed broach, but when we use the composite beam, we use the broach and a curette. I have to clarify now, when doing cemented normal stems, we should not use curette to remove this cancellous bone as we need it. So what happens then when we implant this one? It's got cancellous bone, cement mantle all around, stem in the middle, and there's no contact with the cortex. Unlike here, there's no cancellous bone. The implant has contact with the cortex and it's well fixed. So to put it simple, I always think of it, this is like pretty much cementing an uncemented stem. So you're having an uncemented stem, different philosophy and design, I know, but putting a rim of cement. And there comes what we call the French paradox, where they used to say you put a big stem, little cement, and you have good results. Then we come to the uncemented stems, which depends on another viscoelastic property, which is stress relaxation. And we have to be clear that, well, for this to be stable it depends on the initial stability. We need to have a proper press fit at the beginning. And then according to the design, we will allow either on growth or in growth of the implant. And as we can see here, if that's the implant and the bone with the coating, the bone, in growth happens here. So actually this is pretty much on growth. In growth will happen on the implant itself. Then that's another diagram to illustrate the different interface that we have. So we have with the cemented bone, cement, and metal. So two interfaces, while here we have mainly the bone and the metal. So this is more of a biological fixation depending on the bone growth. The design itself can make a huge difference. So it should allow normal transmission of biomechanical forces across the joints. So this is just a simple thing showing three common cemented stems, the old Charlie, Exeter, and the C stem. And this is just a cross-section showing different shapes of them, and this is different distribution of forces. Same applies when we use proximal coated, fully coated cemented implants. So this is very important, and it's something we need to be familiar with. Materials, as we mentioned, materials was very crucial in deciding the history of total hip replacement. And knowing properties of the material is very important. So stress and strain, Young's modulus of elasticity is very important, seeing where our cortical bone, cancellous bone lies, and where the other material, how stiff, how hard, with different properties of brittleness, toughness, all this very important, and this gives us idea about what implants and what materials we should use. Bearing, different bearings are available in a total hip replacement. So this here, for example, this is uncemented cups, and we can see we can put a polyethylene liner, which can accommodate either a metal or a ceramic head, or we can use a ceramic liner with a ceramic head. Another bearing, it's metal on metal, again, not the subject of today, and the DM or the dual mobility cups, which with the cup, there's a metal liner in, and then like a bipolar head, either with metal and polyethylene, or it can be ceramic and polyethylene. And DMs are, well, not widely used everywhere, but there are certain areas of the world. France, for example, they are quite fan of DMs. Bearing, this diagram just to show simply the difference in bearing compared to different metals. I mean, this is ceramic on poly, and this is metal on metal, and this is ceramic on ceramic. We can see the difference. So, and we just need to clarify, it is not only the number, it is the number and the size, which matters with the allergy and the reaction that happens out of the bearing. So after this, which implants shall we use? So lots of implants are there, and I will suggest, so we use tools to help us to use this. We use approved things. Joint registry, something very important. And again, we had a touch on it in the previous talk about the Denmark or the Scandinavian joint registry, which is the oldest, the Swedish is the oldest joint registry. For example, this is from the UK 1, 2024, and this is 1 gram, just showing, tell us, for example, the trends on what's happening, hybrid being the most common, uncemented. Saying this, if we go through the registry, we'll see data about every single implant, age, group, type of fixation, and we can decide which implants we use. But we need to stress the NGR is not a study. This is just observational study. It's not a scientific statistical study. Other thing is the ODIP, which is the Orthopedic Data Evaluation Panel, which is available for all the implants should be used on the market. Well, the number there will prevent the number of years the product has been with evidence. A is the strength of the evidence, and the star is the rate of revision being less than 5% and 10 years. So all we need to know, whatever implant we need to know our implant inside out. And in general, I don't advise having a big menu of implants around to play with. I would rather have 2 implants, for example, know them inside out, and I can do whatever I want with them. So surgical aim, what are we aiming when we decided to go for a hip replacement? So we need to have a stable joint with equal leg length. So this will be the aim of what we're doing. So to achieve this, we need to restore back again our center of rotation, our leg length, and our offset. And just to clarify, the offset is just the distance from the center of the head or center of rotation to the perpendicular to aligned center of the medulla. So this will be the offset. So how can we achieve this? So this is the pelvis, So this is the pelvis, and these are the implants that we have. So we have to play with this to try to achieve our previous goals. So center of rotation, for example, reaming where we should be, this will provide us with the center of rotation. So reaming where we are. And then so moving the cup up, this can change the length of the leg, or moving the cup medially, I will change the offset. So by the cup, I can get the center of rotation and I can affect the length and the offset. Using the liners normally, usual liners are neutral, but there are some offset liners which can help me increase the offset if I want. Heads, we have heads plus and minus heads. Again, they will tend to increase offset and a little bit of length. Just to clarify, on this axis, we will affect length and offset. And this axis only length, and on this axis only offset. Coming to the femoral stem, which we can actually do lots of things with it. So property mainly for the cemented stem, we can change the length we can sink the stem a little bit up and down, which can help us to change the length, which I don't advise doing this much using uncemented stems, as they should fit where they want and they shouldn't be playing around. We can change the offsets of femoral stems. They have either cemented or uncemented. We can get the same shape, but different offsets. This will change the offset, not affecting the length. And we can have different angles. So the angle will increase the length, but decrease the offset. Just need to say that on the varus neck, it's had more offset compared to the valgus neck, but it will have less length. So again, playing with all these factors together, we should try at the end to achieve the stable and equal length joint. Complications. What can happen with a hip replacement? So again, I will try to keep it simple, and I would like to mention, so intraoperative, we did mention now the cement disease, whether some of us might agree it exists, some not, but anyway, we know there's an event that happened that patient can sometimes arrest on table. So something we need to be aware of. And I totally agree with my colleague professor when he mentioned having everyone's attention. I tend to call it cement curve through, actually. Everything stopped, everyone is around, anesthetist is around, no music around until I finish my cementing. Fracture. So fracture can happen during the procedure, either like the top one here, we can see that's an acetabular fracture, and here it was a femoral fracture. Most of these ones, most of them, they don't need anything more, well, of the femur, the cable. Most of the time for the acetabulum, nothing more. Couple of screws might help. But if something we call discontinuity of something more than this, definitely more attention should be paid. Bleeding is very important and something we should be very aware of, as well as nerve injury. And I say aim failed, that after surgery, well, intraoperative, you could not achieve either the stability or the leg length we were looking for. In the first 24 hours, so again, I started with the medical bits because I know us as surgeons tend to sometimes forget this or put them as second. So MI and PE, they can happen, and it's something for all of us to be aware of and keep in mind for our patients in the early post-op. Bleeding, I mentioned bleeding the first 24 hours. Actually, it's mainly because of the screw from the acetabulum. And unfortunately, I've been in places where, well, two different places where I witnessed two events, actually. One of them, unfortunately, the patient didn't make it, and the other one had a very long resuscitation and management because of the screw of the cup. So we need to be very aware of the safe zones and put screws when really needed. I just need to stress again that cup does not depend on the screws for fixation. Well, as a general rule, I know we have some few exceptions in revisions and in bone defects, but all in all, it should have a good press fit to start with, not depending on the screws. So going forward, DVT and PE, we might get for the first few weeks. Infection will stay with us at the risk all the time. Dislocation as well, and periprosthetic fractures. So if the patient fall with the different types of the periprosthetic fractures, either Vancouver A, B, or C. So different fractures can happen anytime. And actually it's proven now that some implants, because of some designs, has got more tendency to have periprosthetic fractures. And now, because of this, for example, the collared uncemented stem is having a good reputation of preventing periprosthetic fractures because it resists the torsion movement with the collar. So there's an evidence now that the collared uncemented stem has got good results and less periprosthetic fractures. Late, we can have again the infection, dislocation, fracture, and then loosening or implant failure. So here, for example, we can see in the top right one, that's a case with the old Charlie, and we can see all the ballooning, very clear loosening around the implants themselves. And the one here, and when we say implant failure, every single part of the implant can fail. This one, for example, was a case where the ceramic liner itself broke, and these ones, ceramic debris doesn't do very well, and it's not easy to deal with. And it's very important to keep in mind what sort of revision head you're going to use and what sort of bearing we're going to use. Implant failure as well, whether it's cemented or uncemented. Well, this is an old Charlie, and actually this one, we got the cup and the head back, and the cup has a big hole in it where the head went through it for this one. And here we can see a very unpleasant X-ray for a failed complete cup. Again, implants can break, even well-proven implants, and we can see either at the neck, at the shaft, or at the tip. This can all happen, and this can all part of implant failure, whether it's associated with some loosening, infection, implant design faulty, but all this can happen, and all this can be tricky to deal with. Coming next, I mean, we talked about the primary. Sometimes we get a complex primary, and what we're seeing now, like I said, more difficult and difficult things. So dysplasia, protrusion like this one, failed complex surgery, AVN, previous trauma, having previous infection, which is, well, a question mark as an indication, or the worthiness with the previous infection. Neurovascular disease, something we should really be careful about. People having Parkinson's, for example, they are quite challenging to do hip replacement for patient with myasthenia gravis, patient with epilepsy. These patients are quite challenging. Spine stiffness, and at the moment, well, all the hip surgeons were putting into consideration the spinopelvic relation, which in some patients, actually, it might need more assessment in the form of more scanning, MRI scan, different views, sitting, well, while sitting, bending, and bending forward. Again, sometimes it makes a difference. And high BMI, well, where I would consider lucky that we have a cutoff of BMI 40, unlike my previous colleague, which mentioned actually they can operate up to 50, which I'm sure all of us has been through one of these patients. It's not the most easy procedure. So new technology, we had a touch on it. Well, it's going to be mainly talking about new materials, using navigation, patient-specific implants, and robotic. At the moment, Mako, which is the one we can see, maybe the most common robotic system available. But all this coming, but I will still say, well, a surgeon still needed, and these are all helping tools. We cannot just depend on them. Patient-specific implants, I had a couple of situations where patient-specific implants didn't look right, and we had to overturn this, and actually our decision was right. So, I mean, experience is still needed, and I don't think we will get rid of the orthopedic surgeons. So just a small example of how challenging things can be. DHS, a procedure we do pretty much every day, can go wrong and things can be complicated. Here, a broken implant. And just the tricky thing here, again, like I said, assessing everything here. This was a short, we revised this, which was a molar one, to a short stem, and the patient did very well. It's all knowing what you're doing, anatomy, and how the stem works. Again, surgery can be quite complex, and nail didn't go well, end up with a proximal femoral replacement. And just out of interest, because this was quite an interesting case, the one I put earlier for loosening. So this patient initially presented with all this loosening, and it was decided to be kept under follow-up. So, but unfortunately, what happened is it broke in the middle. So the patient had all this stem here and had this there and broke in the middle, no quality of bone, and it was very challenging what we can do. So eventually the decision was to go for a total femur replacement. So as we can see, this is what's taken out, what was left. The incision, I have to say, it's quite a brutal one. You have to open the whole leg. This is the implant. This is the post-op x-rays. And like I said, a bit of a challenge that the patient had a revision knee implant. So we had to call the company to try to get their total femur replacement to match the revision knee, which, well, went well surgically. So as a summary, well, total hip replacement, it's the surgery of the century. And I would say do it when only needed. Treat the patient, not the x-ray. Know your implant. Plan your surgery. Use approved implants that works best in your hand. And I think this will be the best thing for our patient. Thank you.
Thank you so much, Dr. Amr Hussein, for this interesting presentation and interesting cases, of course, especially the last case. Thank you so much, sir.
Thank you, Professor.
Thank you, sir. We have a question for you, sir. I think this will be the next presentation of Professor Ramesh Sen. Dr. Tariq is asking about patient may ask if I postpone the operation, it will make it more difficult as the joint will be more eroded and defected.
Well, I don't like to do this surgery as a prophylactic surgery. The thing is, because if does the patient need it now or not? That's the question. If you need it now, I'll go and do it. If you don't need it now, well, don't tell me I'm 60 now, I've got good health, but in 10 years, maybe I'm not going to be in a good health. Fair enough, but I can do the surgery for you today. You might get a complication and you will hate me for the next 10 years. So we did nothing. So I do it when you only need it. And this is where these patients get the best out of it. I don't do it as a prophylactic thing, and I don't advise this.
Yes, sir. Thank you so much, Dr. Am. Thank you so much,
Prof.
sir.
Thanks,
our next speaker will be our dear professor, Professor Ramesh Sen. the ex-president of the Indian Orthopedic Association and the eminent star of hip arthroplasty and hip surgery all over the world. Professor Ramesh, you are very welcome, sir.
Thank you. Good evening.
Good evening, sir. Thank you so much
Yeah.
for joining us, sir.
Yeah. So can I share? So I just want, yeah, that's right. So I just want to know whether is it visible?
It's starting to be shared, sir. Yes,
Okay.
it's visible, sir.
Okay, thank you. So,
Thank you.
thank you, Dr. Elisha. It has been really a privilege to be talking to my friends over there, and definitely this is a lot of thanks to Dr. Professor Elisha. So, I'll be talking the post-traumatic acetabular defect for hip arthroplasty. As we understand that when we are talking about a situation in trauma, we are talking about something which has been prognosticated to be not of that great outcome as a normal hip replacement does. It's about all the replacements we do in a traumatic situation. They're not supposed to be that good in the outcome. And why so? Because if you look at this literature, there are a lot of complications which have been noted in these post-traumatic situations, whether it is a heterotopic ossification, loosening, infection, 5-year survival. And when we talk about acetabular fractures, yes, when you consider the condition when it is being done, there is definitely a significant improvement in pain and function, and that has been noted at 10 years. Now, what are those special things which are different in a post-acetabular scenario? Now we understand that when we are putting a cup in a standard hip also, we take lot many pains to define what should be the position of the cup, what should be the version of the cup, how is the soft tissue. Now, when we take a post-traumatic situation, and especially if there has been no surgery done, it's a kind of a neglected trauma, then everything becomes difficult because the base is already disturbed. We might have an issue with version. We might have an issue in getting the proper inclination because there could be a loss of posterior wall. There could be a medial displacement of the ischium. So all our parameters which we take to put a cup in positions may be altered. Likewise, with the previous, either the trauma or with the surgery, we might have a lot of muscle adhesions, we might have a lot of contractures. And then with the displacement of all these things, there could be a limb length and offset problems also. If it has been operated upon, now we have another set of problems, which could be again lot of fibrosis, adhesions, implants in the way they may come up within the surgical field or they may be around. There could be a vascularity of the femur head, and many a time the femur head may be totally lysis or the total lost. It could be dislocated. It could be avascularity of the acetabular wall also, and a possibility which we always keep in a previously operated case, that is the infection. So looking at all that scenario, the problems of a altered anatomy, the femur head subluxation, the displaced fragments, and the complication of avian lysis, heterotopic ossification, one thing which is consistent, especially in the cases which have been neglected, is the bone defect. Now, this bone defect is a very important issue. When we talk about bone defects in a replacement kind of a situation, we always talk about Peprosky classification. Or we may be talking in the form of a American Academy of Orthopedic Surgeons classification for the defects. But let's come to a point. This is a combination of 170 publications which have been reviewed. And what has been observed in defects is that Peprosky is the most common used, followed by American Academy, and then subsequently other system of classification. But let's look at this statement. Peprosky classification has never been with the specifics of iatrogenic and post-traumatic revision defects. Meaning by Peprosky classification, technically, has not been made for the post-traumatic defects. We had experience of about 274 post-acetabular fracture replacements in last 12 years. And when we published it, we saw that in this situation, getting the reduction itself is difficult and replacement becomes the only alternative. And then we saw that a post-traumatic defect is definitely a different defect than the revision scenario. Why? The loss of bone is an acute cause. It is not a chronic lysis as happened in the revision scenario. The bone quality is usually poor in a revision scenario. It is usually good in a acetabular defect. The lysis or the displacement is on a specific pattern, which in acetabular fracture we described as a lateral classification, which gives us an anatomical criteria of the fragment displacement. So when we have a defect also, it is likely to fall back in that very pattern of displacements. So we may be able to define the pattern. Then posterior wall injury is a very common feature in the neglected scenario in these cases term fractures. While it may not be that common in a revision scenario, we don't talk about isolated posterior wall kind of a problem. Then we are looking for the lines. The medial displacement due to the ischial displacement or a quadrilateral displacement is very usual over there, which may or may not be that usual in a revision scenario. Ischium is mostly intact in the acetabular fracture because the injury is the superior part, which may not be in the revision scenario. And if we look at the application, the discontinuity which happens in acetabular fracture as a transverse fracture or any of those fractures which have gone to non-unions is much more unstable than a kind of a revision scenario. Meaning by this a different characteristic. So basically looking at an acetabular fracture, then we have got three types of things. Either there is a healing or there is a fibrous kind of a healing where there is a reasonable stability and no mobility, or there may be a frank non-union. So depending upon it and depending upon the anatomical classification, we proposed a classification of these defects into 5 types. We'll go each by them. But before doing so, I had this collection of about 99 patients where we had to do THR. I sent all these 99 patients X-rays to different surgeons, about 10 surgeons across, and who were good acetabular surgeon and who were good replacement surgeons. I asked them to classify these very cases with Paprosky method and with this proposed method, and asked them to suggest the kind of a management. So with this kind of a management, asking them to, in the Paprosky, to look for superior defect, collar line, T-drop, additional defect, and likewise the proposed classification to get into these cases, we calculated whatever all of them sent the information. We looked at Krippendorf alpha coefficient, while in Paprosky it was 0.39, with the new classification it was 0.72, meaning by that inter-observer was much better as compared to the Paprosky classification. Then we look at the percentage agreement. If we look at the agreement of 0.8 or more, it was only in 3 in Paprosky, it was 69 for the new classification. So inter-observer agreement was also much better, a kind of an excellence in 69% of the cases in this classification, while on 3. And poor percentage agreement was here in 63, while it was only in 13 of the newly proposed classification. Meaning by this kind of a system of classifying the acetabular fractures was able to yield a standard pattern of defect classification in these trauma cases. And when we looked at the kind of advice given in this situation, that was also technically matching in a particular group of patients. So we will now look at these cases with this classification. If you look at a simple type 1 where is a gross widening of the acetabulum only due to the previous surgery or due to the problem or complication here. So here we do not have much of the issues because the fracture, the implants, if they are within the joint, can be taken out, joint can be cleaned. A regular or routine kind of a reaming is done subsequently, and we can get a good cup positioning and outcome. Another case with a similar kind of a situation with a kind of involvement of the hip. Again, the hip may be little widened out. You go inside it. You may not remove every implant, only that implant which comes on the way, you take it out. Otherwise, you can get a reasonably good outcome in this kind of a situations. Or you look at the 6 years old acetabular fracture with the posterior subluxation. Again, you go with the same kind of a concept, refine it out. So these are all classified as type 1 injuries, which are type 1 classification of a defects, which we take care of it. Now we look at type 2, which are basically the posterior wall supports. Now here is a case, you can see it out in the x-rays. The femur head is broken, the part of it is in, the part of it is out. And now this loss, which is on the posterior superior side, needs to be replaced with the bone graft. And this graft has to be supplemented with the plate to fix that posterior wall. Now, one thing important is to be observed here. If the cup positioning or the component stability is depending upon the ilium and the ischium and the pubis on the anterior side, any graft on the posterior side can do. But if the component stability is not sufficient with the host bone, and it depends upon the defect is big enough that it depends upon a kind of a graft, then it's better to use a augment than a graft. So that is the kind of the learning we have got in these situations, that when component stability is dependent upon the lost area, the graft, then we don't rely on graft, we'll put an augment. But when component stability is inherent between the residual part of the host bone, then we can put any graft as a supplement. Now here also, we had a good ilium, we had a good ischium, component was effective, but we use the rest of the femur head to support the posterior side to give a reasonable kind of a stability. Here again, another case with the same kind of a situation, we are putting up the graft posteriorly. We may put simple 2 screws, but we have, as an acetabular surgeon, always felt much better when we are able to support that graft with the plate and screws, and so we have a reasonably good outcome. Another thing is that the kind of a cup we use must have a kind of a surface to get us a better. And many times it's better to have a multi-hole, and that too with the holes which are relatively peripheral, so that we can have a screw down into the ischium or middle into the pubis or the upper part. So these are the kind of screws we are looking for it. We might have this kind of a situation when, as I was saying it out, the superior stability is not present. It's basically a posterior superior defect. Now, it's a very old case when we did not have the access to these. This is something around in 2005. I had operated upon this case 20 years back, where at that time we only had the cages available to us. And this is one of those cases where we use uncemented cup with the cage which used to be available, called as an octopus cage at that time. Now we don't have this cage availability these days. If the femur head is destroyed and it is no more as a graft available, now that becomes another situation. And here is that situation which we cover by using a kind of augments. So these augments are now supporting the lost bone, the defect in the lost bone, and we are able to get the cup placement along. Now here we can see the implant, the augment, and then the cup placement into this area. Now another thing here is, because we always consider that after any hip trauma, the abductors are relatively weak, especially after posterior dislocation. And when there is an intervention of fixation, they are still weaker. We are going through the glutei. And when there is a replacement also, so they may not achieve the grade 5 power. So if they are low on power, it is safer to go with the dual mobility hip. So when we plan a cup, we plan a good kind of a porous character in the cup outer lining. We look at a multi-hole, especially the holes placed in the periphery. And third, we look at a dual mobility cup in this kind of a situation. Now we come to type 3, meaning by there is a posterior column injury. Now we have two situations. Either this has united or there is a reasonable amount of a fibrous union stable enough to provide a good component stability, or it is a frank non-union, meaning by 3A and 3B. So if we are looking at this situation where the posterior column is gone but has malunited, again, the malunited will have little alteration in the placement of the posterior column, so along with the wall. So we might have something to talk about the posterior ridge, which will not be there. So we have to take care of the proper version. Otherwise, with the same reconstruction, we can do a good job. But if it is not united, now this is the situation when the ischium has shifted medially, and this patient has got a situation where if you look at the gait, he's a young boy, 19 years old, but his gait is altered. And when you counsel that he's too young to go for arthroplasty, the parents are not happy to have that kind of a outcome to their young boy. They say, do something. So when they come late, after he came late after 6 months with this kind of a injury, then obviously we decided that let's go in for, and then we went for its replacement. And when we looked at replacement, this was the situation inside it. We reconstructed that area, put a graft of that area to build up the posterior wall, and then put up this uncemented curve with the ceramic head over there. You can see it out. And now this gives us a much better outcome. Now he has got a better ability to walk around. He's more comfortable. The parents are happy that their son is able to walk properly now. So this is one of that situations of that instability over into this area. Now we have got the another case of a non-union. You can see it out in the oblique views. We are able to see the frank non-union of the posterior column. Now, whenever there is a non-union, now we need that stability of the posterior column before proceeding for cup placement. So again, we put a plate to stabilize it, and then we put the cup onto that area. Another case of a non-union where there is a displacement, again we stabilize and cause these things. Now we go to the type 4, meaning by a kind of a transverse discontinuity, which may have malunited, or there is a fibrous non-union which is stable enough to allow the component to get kind of a purchase, or a component capture is good over there. Or there could be a frank non-union, so-called pelvis discontinuity, defined either as a 4A or as a 4B. Now, this is a situation which was total discontinuity, but there has been a kind of a malunion there, which has led to a stability. Now, it will not have any of the problem in the component of stability. Component can be well positioned there, and you can proceed with this thing. But if this is the situation, now here we have otherwise a kind of a continuity, but it is not regular in the way. So this is a 3-year-old acetabular fracture with a neglected kind of a situation. So what we did in this case, we went for taking out all the extra bone formed. We went from the anterior and did put the lot of that very bone which was developed around, put that bone in the form of a cancerous graft into this area to work on a kind of a filling up the area with so-called impaction grafting. We used a mesh to hold that graft. Now you can see the middle picture, the kind of a planning, and eventually the kind of positioning of the mesh. And then in this grafting, we did a replacement of that area. Now we do the another case over here where we have a total discontinuity, now meaning by no stability. The classical statement here is that we put a trabecular kind of a cup there, then we put a cage, and then a cemented cup can be placed in this kind of a situations. Now we have this situation where is a frank non-union, a kind of a total discontinuity. In this case, what we did was a fixation of the posterior column. Then we used a cage which was used as a fixation device along with it, and on that cage we did a cemented kind of a replacement. This is an interesting case where this case of an acetabular fracture was not properly managed, and this management failed. Then the surgeon did the replacement, which also was not done very properly, and eventually the whole hip went inside it. So now it is a frank discontinuity with the previous hip which needed revision. So what we did was, again, this is about 20 years old case. Again, we realigned the acetabulum, stabilized it, and put a lot of graft into this area, and this the octopus cup kind of a cage we put, which was actually an uncemented kind of a hip at that stage available. This could be that a situation where your half of the ileum is totally gone. Now you can't allow this kind of a situations to go on. Here, what we needed was to reconstruct that ileum and reconstruct the superior part of the hip and then to stabilize it and then to get a cup placement. Or this kind of a situation where all the fragments are relatively unstable. We do not have any continuity between the proximal part of the ileum and the distal part of the ileum. So again, we have the situation, we go for the stabilizing all those fragments first, then getting the reconstruction done and then going for the replacement so that we are able to manage the patient ambulation over there and he can walk around. This is the initial part of his ability, and subsequently we go for the next part when he becomes reasonably stable enough to walk around and get loaded over there and things settle down. Now, the last one in our classification is type 5, that is the anterior column injury. Now, we must appreciate here, anterior column may not be the that much weight bearing. It may aid stability, but it's not that depending on it, the stability depends. It basically stability will depend upon the ilium, it will depend the ischium, and we do have a posterior wall. So even if it is not, one way is that you go inside, you stabilize it over and then you fix it up. But in old cases, we can just push butlet of graft over there and again try stability between the component of ilium ischium. And once we are able to get stability, we may be okay. Like this case, you can see it over here. The anterior column was gone, posterior column was intact. So in this posterior column, we got a stability. For the anterior column, we used a mesh and then added a lot of graft into that area, and we could have a good this stabilization with impaction grafting in this area. Or this kind of a situation where this was a neglected injury, 3 months old, so we went in for the reconstruction by putting a small mesh inside it, then the graft, and then subsequently the reconstruction done with this kind of a situations to get a reasonable kind of a hip replacement, a stable kind of a replacement. Another case with the similar kind of a mesh support and a graft over there, and the another case with the similar kind of a impaction. Here, what is characteristic is posterior column is intact and able to have the cup stability into this area. So when we look at all these cases, we have seen those cases where we have used impaction grafting, we have used structural graft and sometimes allograft, and the various techniques which we used in these fixations. We did publish some of our work in various journals before that about replacement in an acetabulum fracture. But this new classification we proposed about 3 years back, and this is what we have seen. Now, in this classification, then we made a kind of a flow chart how to go for each type of classification. This is already a published material, and now this has been published in the AO website also, where it can be accessed by all the members of the AO. This is the main, these things given in the AO website also. So what we did subsequently was we recalled 100 patients out of the 209 at one point of time about 3 years back. When it was a COVID time, we could recall these patients. We could use EQ5DL scoring system for the outcome depending upon this kind of a reconstructions. And what we found it out, they were reasonably doing well on the scores, very few poor results. Then we had this another kind of a paper which we looked at the satisfaction of these patients vis-a-vis general patients, how they are doing, and we got it. So when we look back at all these cases in acetabulum fractures, we are looking at their displacement, we are looking at the reduction adequacy, we are looking the problem of infection, fibrosis, implant, and then we get to know about the defects, which we can categorize in a particular set of classification and then plan the reconstruction in that way. We can have a much definitive, defined algorithm for the management. Thank you.
Thank you so much, my dear Professor Ramesh, for this very, very interesting talk about the management of post-traumatic acetabular defects in total hip arthroplasty. And thank you, sir, for joining us and for sharing your long experience with us.
Thank you.
I think we have no questions, because I think the presentation is much more than obvious. Every item is quite fulfilled, sir.
Thank you. Thank you.
Thank you, sir. And I hope to see you, sir, in our upcoming conference of the Egyptian Orthopedic Association.
Surely. I'll really be privileged to come. I'll definitely be able to make it up. Thank you for the kind
Thank you so
invitation.
much, sir.
Okay,
Thank
good
you so
night.
much, sir.
Good night to all
Thank
the
you, sir.
participants.
Thank you, sir. Have a nice night. Thank you so much, sir. Our next speaker will be Professor Abdulaziz Al-Khariji from Kingdom Saudi Arabia. Professor Abdulaziz will speak about stability in total hip replacement. Professor Abdulaziz, please.
Yes, good evening, Dr. Muhammad, Prof. Muhammad.
Good evening, sir.
I just want to figure out how to share the slides. If you can give me a minute.
Okay, just open your presentation, sir, and you put on the green button there, share.
I just can't find the green button.
It's down there. It's down there, sir. Share. You are making your presentation from Mac or from
PowerPoint. PowerPoint.
There is the green button down the share. Okay, you can send the presentation to me, sir, and we will share it, and you can speak on it.
Yes.
Just send it to me. Okay, I received that. Give me just 2 minutes, sir. Sir Abdulaziz.
Yes, Prof.
I sent to you the picture of the green button. You have to press on it. You see it, sir? It's down there.
Yeah, it's not appearing on my screen.
Okay. The person in the company that's responsible for sharing the screen is not available now, so we can just postpone for just 1 hour. He will be with us and he will share it. Okay.
No worries. No worries.
It's not a problem for you. Just 1 hour. We will postpone for just 1 hour. Okay. And Dr. Michael will share it.
No problem.
Okay. Thank you so much, sir. So our next speaker will be my dear friend, Dr. Luca Garo from Italy. Dr. Luca.
Hello. Hello.
Hello, Dr. Luca from Vatican Hospital. It's nice to meet you again, sir.
Nice to meet you too. Nice to meet
Thank you so much for joining us, sir. Dr. Luca will speak about anterior approach in hip replacement surgery, which is quite specialized in it. Thank you so much for joining us, sir.
Thank you. Thank you. Thank you. It's such a pleasure for me to stay here.
Thank you, sir.
Let's start.
Yes, please.
Okay, do you see what I see? Yeah?
It's starting, sir. Starting to be shared.
Okay. Do you see my presentation?
Not yet, sir.
Not yet?
Yes, yes, I can see it.
Okay.
Full screen, please, sir.
Yeah.
No, it's stopped sharing, sir.
Why? I don't know why.
Can you share it again? Can you share it again?
Yeah, of course. Is it okay?
It starts to be shared, but not yet. It's sharing, but not shared. It takes time.
I don't know why, because the process. Okay.
Yes, it's shared, sir. Yeah.
Okay.
Full screen, please, sir.
Okay. Is it okay for you?
No, sir. Oh. It's not obvious. When you make full screen, it's not present. Okay, so, we can start without full screen.
Oh, okay.
Okay. Just share again,
sir,
please.
Yeah.
Share again, please, sir.
Yeah.
Yes, it's starting.
Is it okay?
It's starting. It's about to be shared, sir.
Okay. Do you see the presentation?
Not yet. It's sharing, but yes, we can see it, and it's full screen, sir. Okay, thank you so much.
Okay, thank you so much.
Thank you, sir.
So I will talk about the direct anterior approach, and these are my disclosures. And according to the Italian Orthopedic Society, every year in Italy, over thousands of total hip arthroplasty are implanted, just over 85,000 of total knees. And in the recent years, the boom in intervention for the implantation of arthroplastics does not only concern the elderly, but also young people. So that's an evolution over time. Patients ask for absence of pain, reduction in the administration of drugs, good articulation, walk without sticks, no heterometry, no wear of system, and rediscover physical and sporting activity. So these are the recommendations of the Hip Society over the years. And as you can see, now we have to assure walking, swimming, exercise bike, golf, double tennis, hiking, cycling, and also bodybuilding, and also sports if the patient has experience, for example, athletic walking, horse riding, skiing, canoeing, skating, rowing, single tennis. So it's more difficult for us. So there are 5 types of approach, as we know: medial, anterior, anterior lateral, lateral, and posterior lateral. And all these ways have the corresponding minimally invasive approach. As you can see, the anterolateral approach as described by Berger, anterior approach of Joe and Matta, posterolateral minimal by Hartzband, and 2-incision approach also from Berger. So let's start seeing what regards the lateral in the lateral approach. Landmarks are the anterior superior iliac spine and greater trochanter. The incision is about 5 centimeters above the apex of the great trochanter. You have to do an extension along the line of the femoral shaft for approximately 8 centimeters. Then you have to move the tensor fascia lata anteriorly and the gluteus maximum posteriorly. You have to do the fascia incision. Then there is the exposure of the vastus lateralis and gluteus medius. So you have to incise the gluteus medius and vastus lateralis according to the direction of the fibers. So in this case, the muscle spilling technique minimizes the incision of the gluteus medius, but do not abolish it. So you have to incise the muscle. Then you have to dissect the gluteus minimus tendon to expose the anterior portion of the joint capsule. Then you have to do the capsular dissection and hip dislocation. And then the intervention is similar for all the other approach. So let's start seeing the posterior lateral approach. The landmarks are the greater trochanter. You have to do a curvilinear incision of 10 centimeters, about 10 centimeters, 6-8 centimeters proximal and posterior to the posterior limit of the greater trochanter. Carve the incision passing over the posterior portion of the trochanter to continue along the diaphysis. Then you have to detach the piriformis. You have to incise the extrarotators and the capsula. Then you have to incise the quadratus femoris. Near the femoral insertion to protect the nerve. Also, a capsular dissection of the gluteus minimus. And then the intervention is done as the other approaches. So the landmarks are the anterosuperior iliac spine, the most prominent portion of the greater trochanter and the lateral border of the patella. The incision begins 2 centimeters distal and 2 centimeters posterior to the CS and continues for approximately 8 centimeters along the straight line joining the lateral edge of the patella. Once the superficial fascia has been reached, this is incised above the muscle fibers of the tensor fascia lata. Then, in the superficial plane, you reach the septum between sartorius and tensor fascia lata. In the deep plane, you will find the rectus femoris. It's important to isolate the ascending branch of the lateral circumflex in the splitting of the fascia, as you can see, and the femorocutaneous nerve. These are the branches of the lateral circumflex. Then you will find the anterior capsula. You have to incise it. And then you will see the femur, the neck of the femur. And you are able to place the retractors. Then, once you have placed the retractors, you are able to do the osteotomy. And with a tirabuchon-like instrument, you can pull out the head. Once the head is removed, you can broach the acetabular component. As you can see, it's not difficult. You have the complete visualization of the acetabulum. Oh. And do a straight broaching or a reverse, as in this case, a reverse broaching of the femur.
Dr. Luca, the presentations started from the start, sir.
Okay.
Yes, sir. Yes, sir.
You are not seeing the presentation now, right?
No, I can see it, sir. I can see it, sir.
Now?
Yes, I can see it.
Okay. We are in the reverse broaching of the femur. Okay, are you seeing what I see?
Yes, sir. I can see it, sir.
Okay, the final. Yeah, you are able to see the final implantation. Then
yes, I can see it, sir.
Reconstruction, the suture of the fascia. As you can see, it is a very small incision, and then you can suture very well the skin. So how we do it? With a standard table, we start with a traction table, but we found that it's simpler with a standard table with only four retractors, dedicated retractors, a dedicated reamer and broacher, and a dedicated drape. So in this way, it's simpler to do it with the help of the C-arm fluoroscopy to check every time, in every moment, in real time during the surgery, if there is an heterometry. And I think that this is an enormous advantage of this approach. So we have postoperative pain reduction with reduced administration of analgesics, reduction of postoperative pain, and reduction of hospitalization days. Then the DAA has a reduction of postoperative pain, as we can see, a reduction of in hospitalization days and more discharge at home patients, and less dislocation rate. These are data of recent literature. This is a paper that shows the biomarkers of muscle damage, and as you can see, the CK is significantly lower with the DAAs compared to the other approach. This is an image that shows the fibrosis after posterolateral approach versus in the right image versus a DAA, and as you can see, the muscle is totally normal. Also, in obese patients, the DAA group reported less pain, more functionality, and better quality of life. And we can affirm that the DAA benefited obese and non-obese patients, and it's a preferred choice for obese patients. Obviously, if you have experience with the approach. Releases. The releases are helpful when, for example, you have femur that can be gripped up above the incision, and you have to start with the first release in the 6 o'clock position that releases the pubofemoral ligament. The second one is the 12 o'clock release of the superior posterior capsule, and if performed optimally, it guaranteed an excellent exposure, and this technique, I think, that is powerful and reproducible. So we have also in literature low percentage of transfusion, less invasive approach that not involve muscle dissection and incision. It's a very powerful approach that its cost-benefit ratio is very, very good. This is a patient of mine that the left hip, I performed a posterior access 4 years ago, and in the left side, you can see the right hip at 1 year of follow-up with a direct anterior approach. It's the same patient, but as you can see, it's not the same thing. So take-home messages. The hip is the most prosthetic joint ever. So the evolution of system is the evolution of materials, and we have a choice of surgical access based on the patient. But the DAA is the only real muscle sparing approach that guarantees less hospitalization, less blood transfusions, and less dislocation. And at the end, is the most cost-effective approach. Thank you.
Thank you so much, Dr. Luca Garo from Italy, for this interesting talk about direct anterior approach in total hip replacement. Thank you so much, and thank you so much for joining us, sir.
Thank you. Thank you so much. Thank you. It's really a pleasure for me.
Thank you so much, sir. I think we have no more questions. And our next speaker will be Professor Wael Samir from Ain Shams University. Professor Wael will speak about algorithm for PGI diagnosis for periprosthetic joint infection. Professor Wael.
السلام عليكم. أهلا جميعا. I will start sharing from here.
Yes, please, sir.
First of all, much thank for Professor Muhammad Al-Ashhab for the great work you've done and a very great job for these activities. Thank you, Dr. Ashhab. And I hope we can add something for this webinar. We'll talk about the algorithm for the PGI diagnosis. Of course, the presentation of the periprosthetic infection, it is completely different from one patient to another patient. Sometimes the patient comes to us with vague symptoms of prolonged pain and swelling, and without sinus discharge or previous diagnosis of the PGI. Another patient will come to us with a frank infection with radiolucency and the sinus discharging from the pus, which does not need further investigation to prove that this patient is an periprosthetic infection actually. So I will cover in this in these topics only the diagnosis part of my lecture about the ICM definition of the PGI and the new scoring system, and finally we'll introduce algorithm for diagnosis. The management will be covered by Professor Dr. Mahmoud Abdel Karim for the case-based lecture about the management and one-stage versus two-stage revision. First of all, one of the major challenging for the orthopedic surgeon in most of the cases of infection. And we don't still now till 2025, we don't have a test with absolute accuracy with 100 sensitivity and 100 specificity for the diagnosis of infection. So it is a combination between the clinical judgment of the surgeon, the lab test from the peripheral blood, the serum analysis, and the most important part, which most of the data for proper diagnosis of PGI is a synovial fluid analysis, which is completed mostly by the microbiological culture, intraoperative finding, and histological evaluation. So the clinical judgment, one of the most important part, and the clinical judgment should still prevail and guide the physician in the management of the patient. And we should escape from what is called in our career is the denial stage. Our patient is an infected. The index of suspicion is the most important test in the diagnosis of the PGI. Because in some situations, the patient is already infected and you feel as a surgeon is infected, but does not meet the diagnostic criteria for our algorithm or the scoring system developed by the ICM meeting in 2018 in Philadelphia. Next is what are the most important point we cover here. The clinical finding, which is very specific to the infection, which is deep tissue involvement, including sinus tract abscess and extensive necrosis, is a very, very late science for diagnosis of infection. Although it is the most specific science, but is least sensitive for diagnosis of PGI. The painful prosthetic joint is the most sensitive. The earliest sign for the BGI is pain, but the least specific, because we may have a lot of causes for a painful total hip or total knee arthroplasty. The clinical finding differ based on the type of the joint involvement, the timing, and presentation of the BGI. One of the most important aspects we should clarify between what is called the superficial site infection from deep site infection. Most of the surgeon in the denial stage try to convince himself and the patient it is a minor infection, it is a superficial infection, we don't need to go further for diagnosis of infection. It is incompletely unaccepted in the diagnosis of the BGI, because there is no single objective clinical test or imaging approach established to differentiate between the superficial SSI or surgical site infection and the deep site infection. So it should be dealt as it is a deep infection and it is infected prosthetic joints, rather than denial stage and go for management of superficial infection by some sort of antibiotics. It is not accepted in the modern treatment of the BGI. It is recommended through the clinical evaluation, and the early aspiration should be given for the decision. In the second international consensus done by Barvisi in Philadelphia in 2003, they start to clarify the criteria for diagnosis of the BGI, and they put what is called the major criteria and minor criteria. If I have patient with a sinus discharging pus and communicating with the joint, it is definitely infection. If I have a patient with two positive identical organisms in the periprosthetic culture, it is a definitely infection, and we don't need to further for investigation to clarify this is infected or not. We may ask for investigation only for the follow-up and clarify the response to our surgical and medical treatment of this patient. And if we don't have a major criteria, may have one or combination of three of minor criteria. The minor criteria including the combination of elevated CRP and ESR, or one of the important criteria in analysis of the synovial fluid as elevated synovial fluid white blood cells, the change leukocytic stress test, or recently the alpha defensin test, or elevated synovial total leukocytic count with this differential. More important is the percentage of polymorph nuclear leukocytic enzymes, or if we have a single positive culture or a positive histological analysis. If we have three minor criteria, it is a diagnosis of the BGI or one of the major criteria. And this table summarize the important test we can depends on for the diagnosis of the BGI, either from the serum or the synovial analysis, or using the image or the tissue. We can ask the serum or the white blood cells and the differential, the ESR and the CRP or the serum interleukin-6, procalcitonin, D-dimer, and fibrinogen. What is important is the diagnosis or through the proper synovial analysis, the total leukocytic count in the synovial sample, what are the percentage of polymorph nuclear leukocytes from the total white blood cells count in the synovium, the synovial CRP, the leukocytic strep enzyme, streps, or alpha defensin and synovial culture, and the most important recent is the PCR and the next generation sequence. Imaging may add a value, especially in the chronic cases, by using an X-ray, MRI, bone scan, or PET scan. In the tissue, can depend or using the frozen section, histopathology, and the most important is the tissue culture, using sonocation in some cases of chronic infection, with sonocation depends on isolation of the organism through degradation of the biofilm around the prosthesis, or asking for the PCR to identify the proper organism, independent if the patient have already on antibiotics or not. And this is the main advantage of using PCR. What are the cut-off numbers for the acute infection to be diagnosed? In the acute infection, and the meaning of acute infection is the periprosthetic infection within the first 4 weeks after the surgery. Here, the ESR is usually very high, insignificantly to the BGI, and not useful to use the ESR for diagnosis of the BGI in acute situations. But the CRB to be evaluated as a marker for the BGI, which is usually elevated after the surgery and down again after 3 weeks. We can use it as a marker for the BGI if the CRB more than 100 in cases of acute perioperative infection or in case of acute hematogenous infection around the prosthetic joints. And if we have the synovial white blood cells more than 10,000 and synovial polymorphonuclear leukocytes more than 90% of the total leukocytic count from the synovial analysis. In the chronic situation, we know that the immune response is less, so we expected that the numbers will be more or less. If the CRP is only more than 10 milligram per liter with the normal value around 5 milligram per liter, it is a marker of the BGI and should be considered as one of the minor criteria. If the ESR more than 30, it is considered to be one of the minor criteria for diagnosis of infection. Synovial white blood cells, the response will be completely different from the acute response in acute periprosthetic infection, and the chronic situations, we expect the number will more or less, if more than 3,000 only cells per microliter, it is one of the marker of the infection, and polymorphonuclear leukocytes more than 70%. But does the presence of both the ESR and CRB below this threshold rule out of the infection? No. If you have the clinical judgment that the patient is infected, but still the ESR is the CRB is normal, does not rule infection, because the patient may be suppressed by using antibiotics during the infection stage, and the CRB is false negative due to the antibiotics. If the patient is infected by a very slowly growing organism, maybe the response of the body in the form of the CRB and ESR is much less and maybe in a normal values. One of the most important tests is the leukocytic stress, because it is very cheap with a very high sensitivity and specificity for the diagnosis of infection. It detects the presence of a very important enzyme, is the leukocytic stress enzyme, which is enzyme produced by the activated neutrophils inside the synovial fluid. And if it is positive, it is high sensitive and specific in more than 93 to 97% of the cases as sensitivity and specificity. So it is one of the most important tests because it is a very cheap and very sensitive and very specific. The alternative one, which is very expensive, to detect what is called the alpha defensin, which is a antimicrobial peptide secreted also by the activated neutrophils. And the presence of this activated or antimicrobial peptide inside the synovial fluid, this means that we have a high percentage of activated neutrophils against the invading organism. And also, this is a high sensitive and specific, but the main drawback or main disadvantage is that it is very expensive relative to the other leukocytes. One of the growing interest in using the D-dimer in the presence of infection, and as we know, we use the D-dimer in a high volume during the epidemics of the coronavirus. So nowadays, the Z-dimer is also used as a marker for diagnosis of BGI. And the presence of the 3x of the normal value, 3 times, it is one of the markers in the serum for the diagnosis of the BGI. Also, we have the procalcitonin, which is maybe less sensitive, but the combination of procalcitonin and CRB proved to be more reliable than the white blood cells count. Also, the search for the interleukin-6 in the serum and synovial interleukin-6. The combination of the serum interleukin-6 and the CRB, very reliable tool for diagnosis of periprosthetic infection. Also, the synovial fluid interleukin-6, one of the regular tests for the patient with infected prosthetic failure. What about the precautions during the intraoperative culture? And we should change our practice as regard this, change our attitude. We should have multiple culture from different area of the, we should take from the tibial side, from the femoral side, and from inside the joint, from the medial gutter, the lateral gutter, and the any suspected area. So we take about not less than 3 and up to 5 to 6 culture from the paraprosthetic area for the proper diagnosis. And when send this culture for the lab, we should ask for what is called extended culture. We never accept to have a culture after 48 hours with no culture detected. We should ask our lab to extend the duration of the culture for more than 14 days to detect the slowly growing organism, and especially if we ask it for a special infection, as in case of fungal infection. And the most problematic point in the periprosthetic fracture, when you cannot identify the microorganism, what is called the culture in negative BGI. And this is one of the most challenging points in diagnosis of the BGI, which may be in some research up to 40% of the cases of the BGI come to us with culture negative. And in this situation, we should do our best to detect the most important point in the diagnosis and the management, to detect which organism we are dealing with and the sensitivity. By repeating the sample from the synovial fluid, we asking the lab for longer incubation of the culture sample to detect the slow-growing organism, to do what is called the sonication of the implant. Sonication of the implant, it is using of ultrasound for degradation of the biofilm around the extracted processes to get more a chance to detect the microbes inside this biofilm. The using of the PCR, and now it is available and widely used in Egypt for the diagnosis infection. And one of the important advantage of the PCR detection is it is independent of the use of the antibiotics by the patient. In the culture will be affected if the patient is already on antibiotics, and we should withhold the antibiotics for about 14 days before doing the culture. In the PCR situation, we don't need to go to withhold the antibiotics, and it can detect the patient even in under the umbrella of antibiotics. That's the next generation sequence. This is more advanced to detect any infected. They detect the microgene from the organism and may detect a lot of culture negative patient can be detected by the next generation organism, and detect also the patient with polymicrobial infection. Of course, the intraoperative culture is more than accurate than the synovial culture. And every revision total during the arthroplasty, even if you are diagnosing this patient as aseptic loosening, it should be taking culture for every revision case to exclude the presence of infected processes. Is aseptic lesion may be associated with undiagnosed BGI? Yes. About 10% of the culture negative cases contain bacteria when screened by the molecular method at the PCR and the next generation sequence, and some of the cases of aseptic loosening due to culture negative. The bone culture, inconclusive. If it is better than the tissue culture, mostly is the tissue culture is more sensitive than the bone culture. We cannot recommend for or against the bone biopsy to provide additional diagnostic accuracy. Is there any significant difference in the yield of the culture between the preoperative aspiration and the intraoperative culture? Yes, as mentioned before, that the intraoperative culture is more, or have more yielding for diagnosis of BGI in comparative to the preoperative aspiration. The scoring system for the BGI, which is developed 2010, it is a giant step for diagnosis of the infection. They put what's called scoring for each item according to its weight in the diagnosis of the BGI. For example, if the patient have a high CRP more than the cutoff number as described before, in the acute more than 100 and the chronic more than 10, it will take 2. If the patient had D dimer, it will take 2. But for both, we cannot do 4 for this patient. It's only 2. And elevated ESR 1. although the elevated synovial white blood cells or leukocytic esterase or alpha defensin, if we have any one of them is positive according to the criteria mentioned before, as the total synovial white blood cells more than 10,000 or 3,000 in chronic, and if the leukocytic esterase is +2, then the patient will be scored 3. One of them, or if all the three are positive, they take only 3. So, and calculated the total score. If more than 6 or equals to 6, it is completely infection. If less than 2, it is not infected. And if 2 between 5 inclusive, that means we need more further investigation as positive culture, intraoperative purulence, or intraoperative histology to be done. And now we have the smart application for the BGI diagnosis. We can, both for the diagram and first, we can mention if the patient is an acute situation or a chronic situation, and both the number of the CRB, the D-dimer, and the synovial analysis markers. And at the end of the application will tell us if the patient is infected or not infected. We have some cautions during the diagnosis of BGI. We can maybe felt with what's called the false positive or false negative. If a patient with adverse local tissue reaction, inflammatory arthroplasty like rheumatoid may give us the results of a false positive, because most of the patients have a pain after periprosthetic infection, may have an activation of the rheumatoid arthritis, and with high CRB and DSR, sometimes they give false positive with leukocytic esterase for the synovial analysis. So in these cases, we may face what is called false positive. On the other hand, if the patient with a slow or growing organism, the numbers and the marker that are low, and if the patient under antibiotics treatment, they may be diagnosed as false negative. Sorry. The imaging technique, we can use the ultrasound for guided aspiration. The C and MRI may be used for the extent and detection of any collection about the processes during the debridement. The nuclear medicine, undefined place, but the most important one is the PET scan in some selected case. Finally, I will end by this algorithm. If the patient with a sinus tract with discharging path and connected with the synovial fluid, it is definitely affected because it is one of the major criteria. On the other hand, if we don't have a sinus, so it depends our clinical judgment or clinical suspicion, and ask the patient for serum ESR, CRB, and the dimer. It is the first step for diagnosis of the BGI. And we have two scenarios. If the all negative, we have negative ESR, negative CRB, negative D-dimer, and we have very low clinical suspicious that the patient is infected, so it is not infected. But if any one of them is positive, we have high ESR, high CRB, high D-dimer, and we have clinical suspicion. If any one of them are positive, but to exclude to be not infected, we should have all these three are negative. So if any positive, the second step immediately will be synovial aspiration and ask for the synovial white blood cells, the synovial leukocytic esterase, alpha defensin, polymorph, and the culture. And according to the weight of each one, we can add this scoring system. If we totally with the elevated ESR and CRB or D-dimer, and though it is meet the ICM definition and the calculation of the score is more than and equal 6, so it is infected. The other scenario after doing this, it still does not meet the ICM definition. It is mean less than 2, so it is not infected. But maybe possible infection if between 2 and 5. So it is a possible infection by this ICM definition or dry tab. So we ask themselves if the patient will be planned for surgery, because if we have another indication for the surgery, loosening or dislocation. So already the surgery will be planned, or the surgery unplanned. If it planned, we'll repeat the examination again for the white blood cells, the leukocytic and alpha defensin, and ask for the culture, purulence, and histology next generation. If we have intraoperative variances, this is one of the high score, will add more score. If we get positive culture, single positive culture, and if we had positive by the PCR or next generation sequence, and more the score is more higher, so it is now, it is meets the ICM criteria and 6, so it is infected. If still does not meet the ICM, it is not infected. But if the surgery unplanned, we repeat the aspiration and ask for more for the synovial analysis. If it's still not or dry tap, we cannot aspiration, and this is the only rule for the testing with the bone scan and the PET scan. And if any time, if we have two positive culture with the same organism, this is one of the major criteria for the infection, so it is infected. And this is how to summarize or how to deal with a BGI in a simplified algorithm. Our take-home message is that the new biomarker test and the extended culture at a great value for the BGI, and especially the more genetics next generation sequence and the PCR adding more value for the diagnosis of this challenging case, and the new validating scoring system is a right step for the diagnosis of the BGI of this challenging problem. Thank you.
Thank you so much, Professor Wael Samir, for this very interesting talk about PGI. We have just one question, and you have mentioned already the answer in your last algorithm. The last algorithm you have mentioned it, sir. But from Dr. Shalabi, who was asking a question, I think he's not obvious to me. Okay, thank you so much, Professor Wael, for this interesting talk. And the completion of your talk, sir, will be Professor Mahmoud Abdel Karim from Cairo University. You are very welcome, Professor Mahmoud. Thank you so much for joining us.
Assalamu alaikum. Thank you very much, Professor Al-Ashhab. I'm quite delighted to join this HIPS Specialty Day, and thank you very much for the kind invitation. I really enjoyed most of the talks, and just as you have correctly mentioned, I thought with Professor Wael, which I enjoyed a lot his talk, just to present a case-based discussion based on the diagnosis he just mentioned about. Forgive my voice, I have viral laryngitis. I think quite a few of us had this. So I'll try to make my voice clear as much as I could. I'm Mahmoud Abdel Karim. I work in Cairo University hospitals. So let me start with a case of male patient, 24 years old, who has had ACL injury in 2020, as you could see here on the MRI scan. And then a standard ACL reco was done by a top-notch arthroscopy surgeon. Everything went very well. And uneventful wound healing and removal of stitches done as per routine. Then he presented to his surgeon with signs of infection after removal of stitches around 3 weeks. So I think the next step, as correctly has been done, aspiration was done, and it revealed disturbed discolored fluid, which was sent for culture and sensitivity. Now, management options. His surgeon decided to proceed immediately with arthroscopic debridement, I mean the next day, without waiting for the culture results, because sometimes it takes a long time. Intraoperatively, the cartilage looked pristine though, but with a bit of altered blackish discoloration of the suprapatellar pouch. He did the arthroscopic debridement along with irrigation with gentamicin. Then waiting for the culture results, which came as mucormycosis. I thought to present today rather unusual presentation of PGI, just to appreciate the fact not all organisms we are going to face, especially in Egypt, are quite classic or conventional or typical ones. Mucormycosis is an aggressive fungal infection, and we started now to face worldwide several fungal infections, including that. What is the story behind that? If you remember in my first slide, I said this patient has had ACL injury in 2020 during COVID time. Unfortunately, he had preoperative fever, but didn't tell his surgeon. The family denied that. They said, no need to tell the surgeon. Unfortunately, at that time, fever isn't just a fever. Obviously, it was COVID. So what are the challenges in fungal cultures? Well, up to 46% of fungal PGI may be culture negative because of the organism isolation difficulty. And in addition to all the precautions mentioned by Professor Wael, they usually say that fungal culture should be held for a minimum of 5 to 14 days, and ideally should be held for 4 weeks after incubation. In suspected fungal PGI, especially because of their indolent growth nature. Alternatively, which I personally started to use in the last few years, the blood culture bottles. And the blood culture media actually decrease the time to detection during analytical phase with full spectrum of blood culture media solution. Not only, I'm not referring here to only the fungal, but also to the aerobic, anaerobic bacteria, and even Mycobacterium TB. It improves the time to detect and organism recovery from both adult and pediatric patients. There is actually a specific, which is called BD Bactic, which is the one of the commonest brands for myco and fungal lytic culture vials for recovery of mycobacteria, yeast, and fungi from blood. We all know that fungal infections are quite challenging, and that's why they require a systematic approach. Increased awareness nowadays is essential when patients with painful arthroplasty, especially if they have immunosuppression, significant comorbidities, multiple surgeries, and history of drug use. And obviously, at the time of COVID, this also was one of the risk factors. In fact, I'm delighted to work along one of my dearest colleagues who is infectious disease specialist. I started working with him for the last 6 years or more. And actually, he has published in collaboration with other authors about diabetes mellitus coronavirus disease, COVID-19 associated mucormycosis, and they call it CAM. And at that time, it's they called it a wake-up call from Egypt. So mucormycosis, a delay in treatment of even a few days, can greatly reduce the survival rate. Even with early treatment, it can be hard to cure. For all types of mucormycosis, sometimes the mortality rate is around 54%. When it comes to the disseminated mucormycosis, it's almost always fatal. Back to our case, when such challenging, not only challenging surgically or decision-making, but also emotionally debilitating, not only for the patient and his family, but also for the surgeon. Now, the recommendation at that time that among the options of treatment is amputation, or to keep the limb. Well, the surgeon decided he was very keen to keep the limb as much as they could, especially and luckily that this mucormycosis was not disseminated elsewhere. So open debridement after a week along with irrigation, and the bone was found to be brittle along with several necrotic foci. Then the patient had several debridements along with successive bony resections. And these are some photos which I've taken from the surgeon. And it shows how necrotic the bone was. But at the very same time, the cartilage wasn't looking very bad. He decided to remove as much bone as he could because the alternative is disarticulation for the start, above knee amputation, and later on might go even to disarticulation. And I got this photograph from one of the articles from medical mycology case reports, and it showed the how it looks, the osteoarticular mucormycosis of the distal femur, again, in a similar post-COVID-19 patient, but for this case, it was managed by amputation. Well, after several debridements, the infection still persists. The infectious disease specialist even recommended this articulation. Obviously, family were quite anxious and not obviously keen to proceed with this articulation. And that's why this case was emotionally debilitating to everyone. Well, it has been discussed with the family that another aggressive oncological type debridement will be done. And this was done along with distal femoral bisection or bivalved osteotomy with aggressive debridement and careful curettage of the whole femur proximally, along with putting a cement spacer. And as you could see, it's like something like eccentrocontract osteotomy, but distal, where you can split the bone and then put some circulage and insert your spacer. And these are the photos from this operation. Further management at this time, this patient was referred to me just to manage. And again, after careful and comprehensive family counseling, I decided that even if the infection, it seemed that we were winning with infection. However, I decided for such aggressive organism, I go again for redebridement, spacer exchange, and to add antifungal high doses along with, and the most important step for that is obtaining further specimens and histopathology, because there is no, ideal tool or diagnostic test apart from cultures when it comes to the fungal infections. We have to appreciate that fungal infections are quite difficult to treat. They include Candida species in addition to the other unusual organisms like the one I'm presenting today. Usually you can use amphotericin B, liposomal 1.4 gram, or voriconazole 0.4 gram as well. Again, further to what have been mentioned in the previous excellent lecture, the second international consensus meeting, or ICM-FILI, has a great application both on Android and iPhone, and you can explore different tools which can augment your PGI management, including the antimicrobial treatment. And in this table, I usually keep it on my mobile. And you can see here every single antimicrobial which can be added to the cement, including the antifungals, including amphotericin and voriconazole. Not only that, the Pro Implant Foundation, their pocket guide, which is new one to diagnosis and treatment to periprosthetic joint infection, they have also a great table, might be concise. Again, they usually advise amphotericin B liposomal 0.4 gram and voriconazole 0.4 gram to be added to the cement spacer. I came across this question: which antifungal agents are heat stable? What dose of these agents should be used in cement spacers for fungal PGI? Well, again, amphotericin B and voriconazole. Both are in powder form. They said that the specific dose isn't known. However, they usually say between 150 to 1,500 milligrams per 1 pack of cement of amphotericin B liposomal 1 and 200 to 1,000 milligrams of voriconazole. When it comes to the spacers, some tips and tricks. Usually we mix the powder with the monomer first, but the surgeon might have the temptation to add the antibiotic powder to the powder and then mix it with the liquid. This is absolutely not recommended. It's better to leave the antibiotic powder to be added at the end, to be on the surface for better elution. And also, it's important to leave as many large crystals intact, because this would increase the porous mixture creation and increase the antibiotic elution. We usually ask the nurses, if they help us at that time, please do not fully crush the antibiotic crystals and even do what we call whipping or pour mixing technique. The technique I usually use in these cases, the static spacers, especially with such big bone defect, what's called apple core. And what I mean by that, there is a central bar of metal and then the cement apple core. And then on the periphery, you can add another pack of cement or 2 packs of cement or whatever. And then to this superficial or outer cement skin, you can add your antibiotic or antifungal according to the case. And that's how it works. So central core of metal and then some cement. And then on the periphery or on the superficial or cement skin, you can add the antifungal and or the antibiotics as per case. Do not forget that some cases might have associated or combined with bacterial infection, at which time you might also add some antibiotics. That's what I've done for the case using special some rush pins. I prefer this technique because it's easier than to cut in the middle because some might use long nails and then it's entitled to be removed by cutting it in the middle when you take the patient back to theater for removal of the spacer. But here you can just pull the rasping from, or C-nails or whatever you use it. It could be removed easily. Again, I added this amphotericin B, but not the standard one, but the liposomal, because they usually mention that the standard amphotericin B, which is not liposomal, usually forms covalent cross-links with polymethyl methacrylate, which does not elute. At this point, again, I was involving the ID specialist and the clinical pharmacist, and I think it was quite expensive medication at this point. The antifungal ambisome used was equal to cost, its cost was about 40,000 Egyptian baht, which is at that time $1.5 grand of dollars. That's how it looks intraoperatively, but and that's the X-ray just for more fixation, because again, stability would aid in getting rid of infection. As I mentioned before, I took some cultures, and thankfully the fungal cultures came back with no growth. Bacterial cultures are very, very important in this case, as I mentioned, from repetitive surgeries, and also in such immunocompromised patient, you might get associated bacterial infection as well. Luckily and thankfully, there was no bacterial growth in the culture again. Wound close follow-up was done, monitoring the patient with local systemic signs of infection. I usually ask the patient family to prepare for me this nice table, including the dates, the CRP, the ESR, any remarks, and even the hemoglobin or otherwise. So we usually, as well mentioned, we don't need to, for the inflammatory markers, to normalize 100%, but we usually follow the trend. What about why didn't use leukocyte esterase? Well, they usually say no added benefit here. Yeast cells are often difficult to distinguish from red cells and amorphous crystals when it comes to the fungal infections. What about alpha defensin? Again, I'm trying to reflect on the previous lecture. Well, I came across only one study which reported 6 fungal PGI diagnosed by positive alpha defense positive culture. So it might have a role in the fungal, however, further studies are required. What about BioFire? Again, I didn't use it in this case. And it does include in the joint panel, joint infection panel, Candida and Candida albicans. That's another case, not the same case. However, it doesn't include mucormycosis, but still the next generation sequencing, you still could use it in such atypical infection, but it's quite expensive. What antifungal routes of administration, duration of treatments, I mean to be used systemically in addition to the ones which used in the cement spacer. Again, fluconazole by oral or intravenous, and also amphotericin B as secondary consideration. If you are going to do a 2-stage revision, then they usually recommend a minimum of duration of treatment in the interval of 6 weeks. But following the revision, you know what is the recommendation for such challenging infection? Fluconazole 400 milligrams for up to 6 months, from 3 to 6 months if tolerated. Taking the patient back to theater about 4 months from my previous debridement, because we have to prepare the prosthesis, cost implications, and financial issues. I found that after removal of the cement spacer, bone formation medially and medially and posteriorly beside the vessels. I presented this case and I shared this case with quite a few colleagues, including from US and everywhere. And I told them I'm going to do arthroplasty distal femoral replacement. Would this be looking crazy? And we might get the risk of reinfection is always there. However, we decided after careful counseling of the family, as I just mentioned previously, that we'll go for that, bearing in mind that the risk of recurrent infection might occur. And these are some intraoperative photos of implanting the distal femoral replacement, as you could see. And this is, Okay, the video isn't working, but anyway, that's how we usually like to do the distal femoral replacement or the total knee arthroplasty, generally midline. But here, because of the previous surgery, there are some tips and tricks, but I followed the same incision rather than creating another incision medially and going through a different plan. But because of the magnitude of bony resection, this wasn't very difficult approaching that from the lateral aspects. That's the post-op X-ray. Again, after that, we have to give, as I just mentioned, fluconazole 400 milligrams daily should be continued for 3 to 6 months. I think with this patient, he continued up to 4 months till he got wasn't able to tolerate more. 2 years follow-up, and the patient visited me, and he was doing absolutely fine so far. We are about to publish that, but we didn't want to publish that before 2 years. But again, we might be lucky, but we are waiting for more follow-up, and hopefully the patient might not get any recurrence. So fungal osteomyelitis is quite rare, but I'd say nowadays in Egypt, when it comes to fungal PGI and different countries, isn't very uncommon, to be honest. Potentially aggressive. Some types like this rare or unusual case of mucormycosis might have devastating complications, sometimes leading to severe joint and bone compromises that might risk the patient limb or even life. Frequently misdiagnosed due to its rarity, mild insidious initial presentation, which might delay the clinical suspicion by the surgeon. So it's a wake-up call. Be careful, put it among your differential diagnosis. So the take-home message from this case-based discussion, I'd say, the key point to win with the fungal infections usually is timely and early diagnosis. With some atypical cases like, or types like the one I just presented, treatment needs to be very aggressive, combination of aggressive oncological type surgical debridement, and I'd say that's the single most important step in this case. Antifungal agents, and in some cases, unfortunately, like the ones presented in other parts of the literature, amputation and disarticulation might actually be required to save the patient life. In addition, you have to expect extremely emotional outcomes, not only for your patient, but also for the surgeon. وقبل كل هذا ستر ربنا. Thank you so much.
Thank you so much, Professor Mahmoud Abdel Karim. I know you have a tight time because you're in another conference. So many thanks for joining us, sir. It's a great honor. Thank you so much, sir.
Thank you very much.
We have one question from Dr. Ahmed Qasim from Iraq. It's actually a case problem. He's saying that a stable sound total knee replacement 2 years ago, and then acute severe UTI of the replaced total knee, and after substance of the UTI, the knee symptoms subsided. So can regard this an infected total knee or reactive synovitis, although no pain symptoms for 3 months after UTI recovery.
Okay, that's different case. So from what I gather, he meant that the patient after total knee developed UTI and then he's suspicious of some infection or PGI of the total knee. Well, again, if you follow the great algorithm mentioned by Dr. Wael, I treat the UTI aggressively under care of the specialist and also infectious disease specialist, taking due care of what bugs are found in the culture, and I treat that. When it comes to the knee, if in doubt, they usually say cut it out. Here, if in doubt, use the 3 buzzwords, ESR, CRP, trend, in addition to aspiration. So if in doubt, I would never hesitate to aspirate the knee and then send for culture and sensitivity, PNLs, total leukocytic, and all the great tools mentioned by Professor Wael. Then according to the situation, whether it's completely it's clearly infected or not. And I think now you could be able to manage well.
Yes, sir. Another question, Professor Mahmoud, from Dr. Tariq Muhammad. Would you like to aid antifungal prophylactic in immunocompromised patients during arthroplasty?
Well, to be honest, this is a difficult question to answer. However, the standard treatment does not necessarily include that. But for such patients, I always, especially if I'm revising or removal metal work for any revision, I usually take samples, and I usually insist on having cultures. I run this discussion with infectious disease specialists, because don't forget that there are quite a few side effects of the antifungals, let alone the cost. But I think twice before doing that unless it's really necessary. But also, do not forget to examine your patient well, because he might have some fungal infection elsewhere. And in these cases also, I do a proper MRSA screening and other screening as per case.
Yes. Thank you so much, Professor Mahmoud. It was a fantastic presentation, sir. Thank you so much, sir. Our next presentation will be Dr. Ayman Suriel, my dear friend, consultant of orthopedic surgery, Peterborough Hospital, UK. Professor Ayman, thank you so much for being again and again with us. And thank you for your support.
دكتور محمد متشكر جدا ومتشكر على الدعوة الكريمة. طبعا by all means whatever I'll present is not as complex as what has already been presented. These are very, very difficult cases and really challenging. It was really a pleasure to see the last two lectures. Let's start. This is my name. My name is Ayman Suriel. I'm a consultant trauma and orthopedics. I'm head of the hip fracture unit in Northwest Anglia in Cambridgeshire. I follow the footsteps of Martin Parker, who's a great name in hip fracture surgery in the UK. We've got 4 cases to discuss. I will try to go through them in a timely manner so we don't go over the time. If we do have, and then I'll stop short of the last one. The case number 1 is a lady, 90 years old, independent, has a high BMI, she's diabetic, had a mechanical fall, presented to, all the cases I'm going to present have presented to trauma units, trauma teams, different to my care, but then they came to my care at the point of failure of their fixation or needing redo surgery. So that's her presentation. She's got a reverse oblique fracture, but looking carefully at this radiographs, there's evidence of extension into the GT as well. So it's a rather complex injury in a very large patient. She's had an open reduction and nail fixation, and at that point, she was managed by her initial team. Post-operatively, she was discharged home, no concerns about wounds, and came back soon after. That's her follow-up. In about 6 months, she was progressing relatively well, although I haven't seen her at that point, but I reported that according to her clinic letter, that the radiographs were reassuring. There's already some degree of healing, but looking at this radiograph, I think there have been failure of the distal locking, which can happen as autodynamization, but I always become a little bit worried when I start seeing the failure of the distal locking, because unless the healing catches up, you could also very soon be seeing a failure of the proximal fixation. But it seems to be healing well with callus formation, but soon after came back with a failure, spectacular failure of the nail. She came in a lot of pain. I've seen her at that point. We had a long discussion about what to go for. It seems that it was a failure of healing in due time. Couldn't see much happening in terms of her fixation. Her inflammatory markers have always been normal. There was no concerns about infection. And although it looks a little bit arthritic in the hip, but still arthroplasty, I thought, is not really appropriate for her. We've given her a chance at healing again with a redo operation. So I'm a big fan of a technique that our Professor Hassan Zahaf taught us many years ago, is nail plate fixation. So I've done a revision of her gamma nail with a plate fixation. The difference is this nail, the other nail was a 9mm affixus. This is the 13mm gamma nail with reaming, with some subtle correction of deformity. The plate buttresses the lateral cortex, gives us an anti-bending moment, so it helps create sort of a tension band effect on the lateral cortex, and it's a very successful technique that have never failed me. However, despite a clinical improvement, patient being able to weight bear, no wound-related problems, deep samples were normal, she came back after 6 months with a failed fixation. In this occasion, both the nail and the plate have broken. Again, up to the point of failure, she was mobilizing. She was very happy with the second procedure. She was telling me that the second procedure was pain-free. She was very happy, more happier than the first procedure, but it didn't heal, and the nail gave in with a patient with a higher BMI, despite all the precautions and using a bigger nail. So at this point in time, it was a bit of a complex problem. She's got 2 thin cortices for an uncemented revision stem. She's now 91, still high BMI. Her abductors were particularly poor because of calcification and repeat surgery. Still, we've had no evidence of infection. I follow a particular protocol. Is patients coming in after hip fixation surgery, I get CRP, ESR, full blood count on every occasion, whether they're symptomatic or not. And that helps me in decision-making. If they present to the emergency department 3 months down the line, it gives me a clear line of how many tests they have, how many were negative. If the patient had 3 successive normal CRPs, completely normal, less than 5, ESR normal, then I don't really have a reason to suspect infection. So this is what I've done on this occasion. I've done a long stem cemented hemiarthroplasty with a Dal-Miles cable plate. Again, it's a big operation for her. I preferred hemi rather than a total hip because of her poor abductors. I mean, if you're aiming for a total, you probably would go for a dual mobility. And what's better than the larger size unipolar hemiarthroplasty? She's never been symptomatic with her hip arthritis, so I didn't think in 91 years old that would be a problem. Indeed, she was mobilizing after surgery with no pain, and that's her lateral projection. Managed to get good correction of the proximal fragment, is now fixed on the outside, on the inside, with a long stem cemented hemi, which is 220 millimeters, and a GTR plate. Deep samples were taken during every procedure. Whenever we're in, there have been previous operation, we take deep samples. The standard is 6 samples. They all came back as negative, and therefore the post-operative antibiotics which were given prophylactically were stopped. There was a leaky wound post-operatively, which managed with a negative pressure dressing. She has good mobility, and now she's walking with 1 stick. She's pain-free and has been for now 3 months after her surgery. She's been discharged home for some time. This is a second case presentation. This is a patient who presented to another trauma unit with the background of liver cirrhosis, atrial fibrillation, hypertension, cancer prostate. He was managed by a nail fixation, which to my mind is not the best fixation, really. I've given some constructive feedback to the surgeon who did this. There was a few problems here. The guide pin is put to the fracture site. The entry point has been completely missed. The fracture is invarus, so it's not a great. The tip apex distance is not good. So there's a lot of improvement factors to improve here. To the surgeon's defense, it's a very, very large patient with lymphedema. The soft tissue is really difficult to manage and to get around. So the patient presented to clinic soon after, and saying that last couple of days there was increasing pain. So there have been a penetration of the lag screw medially. Though these lag screws are designed to back off laterally, with the grooves in the nail are shallower as you go medially, but the screw went the other way, which suggests there's also a problem with the locking. How the lock screw was applied onto the lag screw is probably not applied into the groove. So patients have never been happy with the procedure. There was no wound-related complications, struggles to mobilize. there was an issue with this patient that the CRP was slightly elevated. It was not elevated in the region of hundreds, but it was always in the region of 12 to 18. And for me, for the inflammatory markers, I am very binary in terms of either they are completely normal or if they're elevated, whatever elevation, they're abnormal for me. And therefore, I was not really convinced that he didn't have an infection. Now, aspiration is one means of trying to detect, but aspiration have got sometimes a very low yield and false negative results. If there's a collection and you don't hit it with the aspiration, you might get a dry tap and think there's no infection here. I think the thing that is most likely to pick up infection is the number of deep samples, and 6 to 7 is the number I go for. I therefore decided to stage this. So I've taken the metals out, taken samples, and waited for 14 days until the samples came back as negative. Strangely enough, after the metals were removed, the CRP went back to 0 to less than 1. So which is, I can't explain, but we didn't find evidence of infection, and therefore the wound healed, and therefore the definitive stage was planned, which was again a long stem hemi in a gentleman who's very frail, mobility is very limited. So I suspect the hemiarthroplasty should suffice for him. The good thing about this procedure, we managed to capture the greater trochanter fragment. So he has actually regained his abductor function that he's never managed to walk with an abductor lurch after his surgery. But once it was fixed, he was finding that much easier to walk on, and he was discharged home with no further complications. This must be at least a year old now. The case number 3 is again a gentleman who's has a high BMI, lymphedema, leg ulcers, and has a subtrochanteric fractures. I find the subtrochanteric fractures particularly problematic, and the rate of complications with fixing them is high. The main issue is always the correction of deformity. And these are the operative images. And my concern with this, seeing this, is that although there have been attempts at an open reduction was not completely done. There is still a flexion deformity. There's a cable holding around the broken fragments, but you can see the cable in thin air, and there is no bone medially. So there's a few things here, together with the fact that the tip apex distance is not really respected, and that screw is particularly high up. So seen in clinic, and then it was obviously failing. There was further displacement. You can see that cable was struggling to hold everything in place. He did present to the trauma service a few weeks after this X-ray with a broken nail. Unfortunately, I couldn't find that radiograph. I suspect he presented to another hospital, and the other hospital decided to transfer to us, asked for a referral, and I accepted the patient. Again, very challenging patient with lymphedema, makes the approach particularly difficult. But my point is always, you have to reduce these anatomically. If you're gonna reduce, you can't really do half a job and leave it like that. So this is what I did. A careful open reduction. It is not a perfect reduction, but it is much better than what was attained previously. 3 cables held it in place. I restricted his weight bearing, although that's not a protocol. The protocol in the UK is all patients having hip surgery, they should be able to weight bear instantly. But the stakes were particularly high with him, and I didn't want to take any further risk. And this is his radiograph at 8 weeks, and they're starting calcification, and he was feeling much better, and he was started in protected weight bearing, and we've not had any problems ever since. Again, deep samples were negative for infection. This is my last case today. And again, she's an 81 years old lady. You can see all my cohort of patients are in that age group. She presented with nail failure. This was done elsewhere. The initial fixation didn't show any concerns. Lots of hypertrophic colors. This fracture wants to heal, and she's not a particularly large lady, so I really can't comment as regards. There was nothing technical within the first operation The body seems to be wanting to heal, but still there was nail failure. So we're suspecting a notching of the nail, what we call nail notching or metal fatigue, because of the lag screw drill touching the metal and causing damage. Anyway, she's an 81 years old lady with non-union 4 months after her index fixation, and now came in with a broken nail, and she needed a reoperation. I elected to redo this, and on repeat surgery, what I found is that segment, because that was a segmental fracture, that segment of the lateral cortex was completely avascular. That was really dead bone, and without lateral continuity, I don't think these patients have a chance. I think without lateral continuity, these fractures will fail. So my redo procedure was a debridement of that area and bone grafting, exchange dreamed nail, and a plate fixation. So the plate helped me to restore some continuity and tension to the lateral cortex, and she felt instantly better. She mobilized quite well after surgery, and at 3 months, she was doing rather well with more callus. I mean, on the lateral projection, you see there is bridging callus to front and back. I put my nail plates, I put them anterolaterally, and they, for the subtrochanteric, always the deformity is flexion and abduction. So an anterolateral plate always does the trick for me. Well, not always, but with a reasonable chances of success. So the key messages is hip fractures are demanding injuries. They're not easy. They're not classically training cases, but the stakes are high. These patients have got one chance, and we've got a principle which is called GIRFT, which is short for get it right first time. You need to get these fractures right first time. Patients are usually frail with little functional reserve. Healing is slow. These patients will not heal in 6 weeks or 3 months. These patients will heal 6 to 9 months at best. So whatever fixation needs to make sure that they're stabilized. The standard UK is weight bearing day one. I appreciate that that's a principle that might not be globally, abiding by, but it's very difficult to tell somebody who's 81 that you cannot weight bear, or you stay in bed for 3 months. What happens in 3 months? They completely decondition, and they will struggle really to rehab from that point. If they're strong enough to partially weight bear, that would be great, but again, that is very unlikely. Redo surgery is very complex, demanding. If an open approach is utilized, my advice, reduce the fracture like you do for a forearm. People are very meticulous when they reduce a radius and ulnar, but for hips, they believe hips are more forgiving. Well, actually, if you open the fracture, then reduce it completely. Do not leave the medial side of the nail uncovered. You need to make sure that you've reduced your fracture perfectly, and that maximizes your chances of patient for success. I would advise a routine inflammatory markers every time patients come to clinic. Quite often patients come back with a failed fixation, and then the question, is it infected? And patients come back with a refracture. You look at their inflammatory markers, their CRP is high, their white cell count is high, their ESR is high, but that could be because of another infection, or indeed because they have a recent aggravation of their hip pain. I get inflammatory markers every time I see them in clinic, and therefore it makes it very easy for me. If there's no clinical concern of infection, and throughout 3 clinical reviews, everything is normal, then it's safe enough to say there's no infection. And that's all my presentation for today. Thank you.
Thank you so much, Professor Ayman Suriel, for presenting these interesting cases. Of course, the key message is that hip fractures are extremely important to obtain a proper reduction. It's not just biological. I do it biological, but regardless of the reduction whatsoever, I have to obtain a proper reduction. I'm right, sir?
Dr. Mohammed, it's very important. If you can do them closed, fantastic. If you can do a maneuver to joystick your femur or anything and get them closed, that would be even better. Not opening them and keeping the soft tissue sleeve is great for healing. But my key message is, if you can't get them closed and you have to open, then there's no excuse. You have to fully reduce them. You can't say that I've opened, but this is as much reduction as I can get. You're opening, you're putting a bone clamp on it, then it needs to be anatomically reduced, because you've already lost your soft tissue sleeve and you've done an open approach. So you can't really do, you can't lose both. You can't lose your soft tissue cover and get a reduction that less than anatomical. It doesn't make sense.
Yes, sir. We have two questions from attendees. First question, did you face weak leg screw purchase in revision of the CM nail cases, or do you use new placement track of the leg screw?
Oh, I do two things. I have access to allograft, which is fresh frozen bone chips. They're ready in my institute, so I use them. And I graft my tracks. So when I take my old nail out, I'm putting a new nail in. I take a one of the guides of the nail, introduce it into the lag screw, and then apply with the trocar, apply my bone graft into that track. So I obliterate the track altogether, and I start a new track for my new screw. Unless the old track is perfect, then I can reuse it again. And as a general trick, when I'm doing my lag screw drill, I go in reverse. That gives me a little bit of compaction of the bone to the sides and give me a little bit of better resistance to pull out.
Yes, sir. The next question from Dr. Ayman Al-Ahwal, when to decide to revise fixation or arthroplasty in implant failure?
You have, Dr. Ayman, you have to assess your patients on individual basis. Many patients, when you look at the general decision making and you see across the globe, if you go towards the UK and the Western Hemisphere, because the patients and next of kin are kind of open to the fact that they accept from you a complication. If you tell them that the fixation failed, okay, they will accept that, and they know that the chances of fixation failure is less than 5%. In the Eastern Hemisphere, because of the nature of how patients perceive bad news, people are more inclined to go to arthroplasty because less chances of failure, but it's a bigger operation. And that is even true for primary surgery. You'll find that a primary hip fracture, an extracapsular, or a basicervical, a basicervical is most likely to, in the Eastern Hemisphere, is likely to get an arthroplasty because we don't want to wait for fracture healing. Let's put a joint replacement in and get it over and done with. Don't wait for fracture healing. But a basicervical fracture in the Western Hemisphere will probably get a fixation. And we know that the chances of failure are about 5%, but the patients will accept that. In redo surgery, things are much more complex because you've got one attempt at fixation. Do you go for a refixation? But my take on it, if the patient has any means of having a successful arthroplasty that is not too invasive, I would go for it. Like if there is a non-united basicervical fracture, whether the head has been damaged or not, I would go for arthroplasty. If the greater trochanter is not healed, I would fix it then. But if the head of the femur is damaged, like case number 2, there has already been a perforation. In this case, because I've done a staged procedure, I managed to go in and assess the damage to the acetabulum. The damage to the acetabulum, patient presented very early. So the damage to the acetabulum was nothing more than 10 millimeters. It's just one impression. It was very close to the fovea. The main weight-bearing area was all intact. So it was fine for me to put a hemiarthroplasty. Otherwise, I've put a total hip replacement in him. So you have to look at your patient on individual basis. Is the joint still intact? Have there been damage to the femoral head? Have there been damage to the acetabulum? What kind of damage to the acetabulum? Is it something really trivial that we can get away with a hemiarthroplasty? But then what is patient's age? If the patient is young, then hemiarthroplasty is of no use. Go for a hip replacement. And even if the patient is old, if there's been a massive defect in the acetabulum, then hemiarthroplasty is not going to do that. So we need to graft that. We've got the femoral head of the patient. You need to graft that and put a total hip replacement on top. I would lean towards arthroplasty if I can. But if arthroplasty, if I've got one of these nail fixations is the level of the subtrochanteric region, that's massive arthroplasty. Am I going to do a proximal femoral replacement? Or am I going to do an uncemented prosthesis with some form of fixation around it? You have to measure the amount of operating. Ideally, the first lady, I could have given her a total hip replacement, but I was worried about further blood loss and I was worried about abductor function. So I've given her a hemi. So that is me trying to limit the amount of operating. You have to calibrate how much operating you're giving this patient. What's the patient's age? This patient's age was 91. So you have to measure your patient on individual basis. And all of you have got plenty of experience, and I'm sure that you'll make the right decision for your patients.
Yes, sir. Thank you, sir. The last question from Dr. Rami Ashur. Why you don't use plate, especially the case shown in failure on the tension side?
Blade plates are particularly good. Some people have got good experience with them in leads. They have used them as with dual plating. My theory and my practice is that the nail gives you a mechanical advantage. The nail goes into the center of the bone. It gives you a less of a lever arm when fixation. Even if you use blade plate, some of the people who use blade plate are advocates for a dual fixation, and we're talking about subtrochanteric fractures. And then dual fixation with two plates becomes rather very tricky. If you've got experience in that region, then by all means. My experience leans more towards a nail plate fixation, and that's how I manage these patients. But yes, blade plates can be a very good, useful tool, and they're very robust and they're very strong, but they're a very special tool that needs particular experience to use it.
Thank you so much, Professor Ayman Suriel, for joining us tonight. I know it was a hard day for you. Thank you so much, sir. Thank you, sir. Thank you, sir. Our next speaker and last speaker will be Dr. Amr Slim from Oswestry, UK. Dr. Amr, I'm very happy to see you again after I met you in UK.
Thanks, Prof. Ashab. It's my pleasure. Thank you.
Thank you, sir.
With my presentation. Oh, sorry.
Not yet.
Yeah. Sorting it out, sorry. So I think I need to restart the application. Just give me 1 minute and I'll be back.
Okay. Take your time.
محمد مفيش مشكلة.
دكتور أيمن حضرتك وحشنا يا دكتور أيمن والله.
تشرفنا يا دكتور محمد.
بجد يعني سعداء بلقاء حضرتك والله يا دكتور أيمن.
تشرفنا ويا ريت نتأنس بحضورك ان شاء الله في انجلترا واشوفك المؤتمر الجاي.
ربنا يخليك يا فندم، ربنا يخليك. ان شاء الله حضرتك معانا في المؤتمر بتاع الجمعيه ان شاء الله طبعا.
باذن الله باذن الله.
ان شاء الله يا فندم، نتشرف بحضرتك يا فندم. دكتور عمرو take your time، احنا مع حضرتك يا فندم.
Thank you.
Okay, yes. Full screen please. Yes sir.
Okay. Right, so I'm going to talk about conversion total hip replacement following hip fracture surgery, which is not very dissimilar from what Dr. Ayman just explained. So this is for all these cases were done in Oswestry, and it's an elective hub. So we are mainly interested in hip arthroplasty, and it's a tertiary referral center. So hip fracture surgery or hip fracture fixation surgery is growing in number, and as a result, secondary issues such as acetabular erosion and non-union, malunion, AVN, and early onset arthritis are seen more frequently these days. And these factors may subsequently lead to conversion total hip replacement, what we call CTHA. So reported complication rates vary widely, and it's between 7.5% to 30%. It's much higher than the primary total hip replacement, where the complication rate is between 2 to 5%. And complications for this cohort include periprosthetic fracture, dislocation, infection, and poor patient-reported outcomes following the surgery. The potential reasons behind this could include the proximal femoral anatomy has been distorted, soft tissue condition is not as good as primary patients, and the impact of the previous implant that was used in the index surgery. Additionally, there is increased cost, which is very important in managing the financial incentives. So I will start talking about each conversion, the challenges, and what we do for that. So starting with the hemiarthroplasty conversions, they are usually due to acetabular erosion, and this means they are late conversions, maybe about 3 to 10 years after the primary surgery. This has implication on the patient's soft tissue condition, the reduced offset, the soft tissue scarring, and also the capsular contracture. Do we need to do further investigations? You can do some to exclude infection. We don't regularly do hip aspiration. We just rely on the clinical assessment, ESR and CRP to exclude infection and the patient general condition. And if it's a very subtle erosion, this is what we usually see nowadays. It's not like the striking erosion that we see in the past. So now it's just subtle erosions. We can confirm that with a CT scan or MRI scan. And also we can confirm that the symptoms are coming from the hip by doing steroid injection in these patients. The challenge here is that the primary operation is usually done through a hard hinge or anterolateral approach. And the question here, would you revise posteriorly or just go through the same anterolateral approach? And it becomes very difficult if you change your approach just for this condition. If you're used to do the posterior approach and used to do the acetabular reaming, the acetabular cup positioning, etc., in a certain way, then it's very difficult to change in this challenging case, and it would add to the difficulty of the procedure. The other problem is, as the offset is reduced and the capsule is contracted in this patient, as most of them are late conversions, and this would be difficult when you try to do the trialing and the reduction. You might find that it's very tight and you may need to do some releases. What we can do in this condition, we do some iliopsoas and rectus release, reflected head of the rectus release, but we need to be very careful in doing that because it goes from a point where it's very tight to it's very loose. So what we recommend is we do partial release and then recheck every single time, recheck the attempt reduction and recheck the soft tissue condition and the tightness. The other problem is the stem version. So usually because hemiarthroplasties in the UK are done hard hinge anterolateral approach, people tend to put them in neutral or slight retroversion to reduce the risk of dislocation anteriorly, but this may pose some difficulty when you are revising it to a total hip replacement. Our recommendation is that if the stem is neutral or antiverted, that's fine, and that's what we want. But if it's retroverted, then probably we just knock it out and revise the stem. And also, if the patient has any thigh pain before the surgery, this may mean that there's some loosening around the stem, and in this situation, we would also revise the stem. And then the next question is, do we go for the long or the standard length? The standard length is about 150 millimeter. The long is maybe I may go to 250 millimeter. I'm talking about the extra stem and the similar versions. So usually we go for the standard length stem unless there is any propagation of the fracture beyond the subtrochanteric area. And then the other thing we need to account for is the cement mantle. If the cement mantle is fine or is good or borderline, we can go with that. But if it's a poor cement mantle, then we would also revise the stem. And if we revise the stem, we can also do the cement in cement revision with short and smaller stem. The other problem is acetabular reaming because the patient has already acetabular erosion. So we don't advise reaming too much because this may increase the risk of medial migration and osteoporosis. So we don't do that. So acetabular reaming should be very limited in these situations. And this is a patient, 78-year-old, left hip hemiarthroplasty done for intracapsular neck femur fracture. Very nice, and then no problems. And then 5 years later, the patient started to complain from hip pain. The patient had X-ray guided injection of a steroid. The pain improved. No clinical symptoms or inflammatory markers were negative for infection. So the patient had revision into total hip replacement. You can see that the GT broke during the surgery, and this brings us back to the point where the soft tissue may be tight, despite the X-ray doesn't look too bad, but the soft tissue condition was very tight, and during the reduction attempt, the GT broke. It wasn't extending into the calcar or down the shaft of the femur, so we just decided to leave it as it is, and the patient didn't have any problems later on. And then the next one is a CM near conversion, and from my opinion, these are the most difficult conversions. If we think that the patient needs arthroplasty, not redo surgery or not refixation, then I think this is one of the most difficult conversions. And the common reasons are head AVN, leg screw cutout, or fracture non-union. They are usually early conversions, unlike the hip hemiarthroplasty, because in these cases, usually the non-union or the AVN present within 6 to 12 months after the index surgery. Again, further investigations, we could do a CT scan to confirm the non-union, also to ascertain the condition of the femoral head. But the problem here is that the abductor tendon and the piriformis are usually violated by the primary operation, and this risk instability, but also increases the risk of heterotopic ossification. So in these patients, we have a very low threshold to use the dual mobility or the lip liner. And for the heterotopic ossification prophylaxis, we give the patient ibuprofen and omeprazole for 6 weeks. The other problem is that the fracture pattern is usually trochanteric, extending sometimes to the subtrochanteric area. So again, in these patients, we'll have a very low threshold to use long stem. This is a case presentation. Again, this is a 73-year-old patient with right subtrochanteric fracture treated with cephalomedullary nail and a cable around the fracture. The fracture didn't heal and went into varus. CT scan confirmed the non-union. The decision was to do arthroplasty. So we, again, as you see here, the fracture propagated into the shaft, and we needed to use some cables in order to secure it in place. And this highlights that the intraoperative fracture rate in this patient is really high, and we should be careful about that. And then this is a AP X-ray, lateral X-ray. Patient didn't have any further problems after that. DHS conversions are usually due to AVN or leg screw cutout, and these are early conversions. Again, we don't have the problem of the or as significant problem as in hemiarthroplasty in terms of the soft tissue condition and the contracture of the capsule. The problem here is mainly that there is a big hole in the greater trochanter from the leg screw. So what we do for that, we take a graft from the femoral head and plug the hole until we do the cementation and leave it there if it's stable. The small holes in the femoral shaft, if they are visible, we can just do a classic way of just, plugging them with our fingers. Usually this can be done for the lateral side, but for the medial side, it's very difficult, and we don't chase that, and we accept the fact that some cement will be outside the canal, but it's not related to any increased risk of failure, as shown by many studies. And then if you choose to use a cemented stem in this situation, you have to be very careful about the holes. And for the big hole, you need to plug it. For the small holes, you can accept the fact that some cement will be outside. And the X-ray wouldn't look very great as in other patients. And then the options for the uncemented, you can use for the standard, or you can use a long stem. In this patient, we still use the standard length. We don't believe in using very long stem for these patients, and it doesn't show to increase the risk of failure. And then this is a case presentation. Again, leg screw cut out with femoral head AVN. And you can see that it's been revised. The hole was plugged with grafted from the femoral head, and been revised by totally cemented implants. And then the last one is the cannulated screws conversions, and these are usually due to AVN or non-union. And my opinion is that these are the least difficult of them. The only problem is the reduced offset. And again, if you try to restore the offset intraoperatively, you may risk having a fracture, and you may need to do releases. This is a case where had intracapsular necropfemur fracture. This was, I believe, a 64-year-old patient and had intracapsular fracture, didn't heal, had a CT scan, confirmed non-union, and then went on and had a revision. And you can see here that despite being the least difficult of the conversion, still the patient sustained a calcar crack extending into the GT, which is visible in the lateral view, and we needed to fix that with a cable intraoperatively. So what does the literature say about these conversions? So this paper, the first one, this is from the US, and they said that there's increased the complication rate, revision, and readmission, and the cost associated with these operations. And the second one is from the Mayo Clinic. Again, they showed less complications rate, but still the complication rate was higher than the primary arthroplasty. And then this paper was published from us in Oswestry, and it confirmed that the complication rate from this fracture is really very high. And I'll talk more about that in the next few slides. So in terms of the PROMs, the median Oxford score in our study increased from 13 preoperatively to 39 postoperatively. So there is a substantial clinical benefit or substantial clinical improvement for these patients in the uncemented and the cemented group. However, they consistently achieved lower scores than the primary hip replacement, where the primary hip replacement scores are usually higher than 40. The overall complication rate in our cohort was 8.4%, which is significantly higher again than the primary hip replacement, which is reported between 2 to 5%. However, this compares favorably to other studies published in the literature, which reported complication rate as high as 30% in this cohort of patients. The survival probability was 96% at 10 years and 80 for the cemented stems and 88 for the uncemented stem. And this shows that cemented stems, despite that the cement may look bad in the post-op X-ray, despite that the cemented stem do better than the uncemented stems. The intraoperative fractures were significantly higher in this patient compared to the primary, and we noticed that the highest fracture rate were in patients with metalwork needed to be removed from inside the canal, as in the CM nail or in the hemiarthroplasty extractions. And the intraoperative rate in this patient were approximately 12%. And in the literature, this is similar to the literature, which is between 9 to 20%. Next is the dislocation. Our dislocation rate was 3.6%, which is not very high, but the highest dislocation in our cohort was mainly due to the CM nail, and we believe this is because the hip abductors and the piriformis tendon have been violated in these patients. And studies that focused on this problem, they reported that the CM nail disrupted the gluteal tendon insertion in 27% of the patients. The dislocation rate reported in the literature following the CM nail varies between 5 to 8%, so it's slightly higher than the one reported in our study. And then the revision rate, the overall revision rate in our study was 2.4%, which, to be honest, is not very different from the primary hip replacement, but this is not in line with the rest of the literature, where the study from the US reported 10.1% compared to 2% in the primary, and another study from the Mayo Clinic reported 11.7% compared to 4% in the primary group. And interesting study by Hernandez et al., this group from the Mayo Clinic, they reported that the conversion hip replacement following hip fracture surgery has a hazard ratio 1.8 for revision compared to the primary and 1.4 compared to the revision. This means that it has a higher risk for revision compared to the revision hip replacement itself. And this finding indicates that the conversion carries a high risk of revision than the primary and the revision THR. And in terms of the cementation, as we explained previously, the Barak grading was strongly related to the size of the cortical defect left after the metalwork removal. And CM nail and DHS were the worst because of the plugs left the holes left by the lag screw. And such defects are thought to prevent the optimal pressurization of the cement, especially in the metaphyseal area, which is the most important area that we need to be careful with pressure. I mean, if there is any defect in the distal, in the shaft, this is less important than if the defect is around the metaphyseal area. However, despite the poor cementation in this group, we haven't found radiological signs of progressive loosening or lysis. And despite the challenges in cementation and the post-op radiological appearance of poor cementation in these patients, the cemented stem survived longer than uncemented stems in conversions. In terms of the heterotopic ossification, particularly the low-grade type, was commonly observed after the in these patients more than the normal cohort, and particularly in the CM nail and hemiarthroplasty conversion. And this is because of the violation of the muscle during the primary surgery. And as I said previously, what we do for prophylaxis is ibuprofen and omeprazole. And another thing we sometimes do is excision of the gluteus minimus muscle during the revision surgery. So the take-home message: don't underestimate the conversion total hip replacement. Intraoperative fractures are more frequent and significantly higher than the primary, and this is especially after the cephalomedullary nail conversions and hemiarthroplasty conversions. The CM nail conversions have the highest rate of developing heterotopic ossification, so we need to appreciate that and give the patients appropriate prophylaxis. Cemented stem show superior survivorship compared to the uncemented stems, and the poor cementation shouldn't worry you too much. And these are the references. Thank you.
Thank you so much, Dr. عمرو سليم, for this very interesting presentation. دكتور عمرو, انت حضرتك فخر للشباب المصري والله.
Thank you.
يعني انت حضرتك لا تتخيل سعادتي لما كنت في اوسوستري ريسيرش داي ساينتفك داي بتاعكم وحضرتك فزت بالكاب اوف ذا داي. I was very pleasant in this, very happy with this huge achievement. فيعني ربنا يحميكم ويحفظكم، وانا سعيد جدا بانك معانا. ويعني ده زي ما بنقول كده مسك الختام يا دكتور عمرو لليوم. By the presentation of Dr. Amri Slim, we come to the end of the day. All the presentations will be shortly on the Egyptian Orthopedic Association YouTube channel. And I hope you all the best and wishing you all the best. And I will see you after 1 month in the knee specialty day. Thank you so much. وتصبحوا على خير. شكرا دكتور عمرو بيه. متشكرين يا فندم. شكرا.